Ladies and gentlemen, I think we will now give it a start, please, and apologies for starting this morning's meeting late, but technology seems to have got the better of us. There was a suggestion that everything is in meltdown. May I just remind members this meeting is being recorded, but just not being broadcast live. So all the usual protocols, which I will go through in a minute, need to still remain, please. So good morning. It is now 10:09 on Monday, the 12th of June, 2023. This is the first meeting for this council year, so I'd like to welcome members old and new to the committee. This is a Health and Care Overview and Scrutiny Committee. And when we talk about health, we mean physical health as well as mental health. And just like there is a parity of esteem for mental health and physical health, our role has a parity for health and care, and not just when we all get to the front door of the hospital, but in everything that we do. So welcome to councillors and to our guests. I am your Chair, County Councillor Jeremy Pert. I would like to make a number of introductory comments before we start today's meeting as follows. Firstly, to thank those members who have retired from our previous committee. It is unusual for us to lose a third of the membership, and it will no doubt take a number of meetings just to get things to settle down. So thank you to District and Borough Councillors Pip Haddon from Cannock Chase, Patricia Ackroyd from East Staffs, Mike Wilcox from Lichfield, Lynn Hingley from South Staffs, Barbara Hughes from Stafford Moorlands, and Daniel Maycock, who is still with us in a supporting role today. So thank you for your support and thank those members for their support and interest in the health and care of our residents in the county. I would like to, I'll come to you when I've finished. I would like to welcome councillors Monica Holton, Leona Lung, who is going to be joining us very shortly, John Jones, and anyone else I have missed, which I think is Paula Stanton, and we'll come to that in a minute, please. I would also like to thank County Councillor Mike Sutherland for standing into the breach last year, and it's a popular welcome back, albeit apologies from Councillor Kath Perry. Thank you to those people who attended the District and Borough briefing. We did record the session. It's just 55 minutes. So for those who missed it, please take the opportunity to look through the slides and settle back in an armchair and watch it. It covered the terms of reference of this committee, and it is the basic building blocks to help you and your authorities get the most out of this and your own committee. The work between county and districts and boroughs is really crucial, as we all have a role to play in the health of our communities, especially when we look at healthy life expectancy and the differences between certain populations within our communities. The districts and boroughs have certain levers that are really important to improve the lives of our residents, for example, in housing and in leisure. For all members, can I remind you to have a look at your declarations of interest and to keep them updated. And when there is something specific to this agenda, please declare them in advance. So on to more on health and care related comments. I note that the Midlands Partnership Foundation Trust, formerly known as MPFT, has recently been awarded university hospital status and is now known as Midlands Foundation University Partnership Foundation Trust, also MPFT, through their work with Keele University, who are a renowned centre of excellence for things like their work during the COVID pandemic. Does committee want to congratulate MPFT in their recent recognition as a University Trust Hospital? Yes, Chair. Okay, are we all in agreement? Okay, thank you. I will ask the officers to make committee's views known. Thank you. And finally from me, the joint code of practice and way of working on health between county and district boroughs was approved by the County Council at its meeting on Thursday the 18th of May, and this will now form part of the Constitution. All district and borough leads will now need to look to do the same as part of your own reviews of your own constitutions, and I would ask that you take that forwards so that we're all of the same position. I should just mention in passing that it did go to the Leaders Board in March, so we already have agreement from your officers and within your own democratic system. So let's move on to today's agenda. We've already covered the fact that today's meeting is being recorded, if not beamed live, and there is a cut-off about 20 seconds after the equipment has stopped. So please do bear that in mind, particularly when we get to towards the end of the agenda. All voting committee members are in person, and there is a variety of our guests who are in person and in virtual attendance. There's something I always say at the beginning of the committee meeting, which is for our guests to accept that members have read and digested the papers provided, and as a result, if our guests could take 5 and no more than 10 minutes, depending on the item, to present a summary of those papers and the issues, I'd be grateful, please. And can we as committee please focus on the tangible outcomes for the residents of Staffordshire and use the data and experiences that we have to sharpen the quality of debate and scrutiny so that we can provide assurance and reassurance that things within the health and care system in Staffordshire are going in the right direction. So before I move on to the agenda fully, I noticed that, John, you indicated, is it related?
Yeah, it's all right, thank you. The moment has passed. It was a bit of brain fade on my part anyway. Anyway.
That's fine, thank you. Charlotte, is this part of the agenda or can I move on to the agenda?
That's the declaration of interest.
That's fine, you're doing it in advance, that's good. You're usually in advance. So let's start with the apologies, shall we?
Good morning, Chairman. I've received apologies from Councillors Perry, Councillor Chapman, Councillor Bain, with Councillor Maycock as attending as a substitute, and Councillor Williams with Councillor Standing attending as a substitute.
Thank you, Phil.
Mr. Chairman, my apologies. I have to leave to go to a funeral around about 11:45.
Understand, thank you.
Thank you.
And just, I should have probably said 2 other things in passing. If members, due to the heat today, want to take their jackets off, and for ladies the equivalent, then please feel free. And can I also just make a suggestion during the heat that we encourage all of our colleagues to check on their friends and neighbours to make sure that they are safe and well. I don't normally say those sorts of things, but I think it's just really important just to remember the impact that this weather can have on individuals. So, declarations of interest. Charlotte.
Yes, just to declare that I'm Vice President of the British Fluoridation Society. Thank you.
Thank you. Duly noted. Anne Edgeler.
Thank you very much, Chairman, and good morning, everyone. Yes, I'm Partner Governor for the Midland Partnership University Foundation Trust.
Thank you. Bernard Peters. Thank you. And can I just confirm for the minutes that we are quorate? Given the number of people in this room, I would think we are.
Yes, Chair.
Thank you. I need to take my shoes and socks off just to be able to do all the counting. Thank you. So, minutes. Item number 3, to approve the minutes of the meeting of the 20th of March 2023. Can I ask if the minutes are a true record of our last meeting for those of you who were there? Yes. I've seen 1, I've seen 2. Okay, are we in agreement for those who were there? Yep. That's fine, thank you. I'm reliably informed that all actions have been followed up on and the information has been circulated, and equally from today's meeting onwards we will capture those actions into an action log to help track the agreed actions, just to make sure we have closed them out in due order. Item number 4 is primary care dental overview, and we have 2 people with us. We've got Tracy Shewan, who's in the chamber. Good morning, Tracy. And Chris Bird, who is virtual. Shall we hand over to you, Chris?
Yeah, thank you, Chair. Hopefully the issues have been resolved and you can see and hear me okay. We were also due to be accompanied today by members of the NHS England dentistry team, and I'll talk a little bit about those in my summary, but that's not been possible, I'm afraid. So apologies for that. And it does mean that the information we're able to provide to committee today may be somewhat constrained, but I'm more than happy to take questions and comments away and deal with them offline if that's okay. So there is a short report in the papers. if I just pick out some salient points, and then, as I say, more than happy to take questions and comments. So, NHS dentistry, along with pharmacy and optometry, are new delegations to the ICB with effect the 1st of April. That's the same for all ICBs across the country. And for us in the West Midlands, we agreed that as part of taking on those delegations, we would adopt a two-phase approach that would play out in the first and second half of the 23-24 year. First phase would be to really understand in depth the legacy that we're going to inherit from NHS England in terms of operational performance and the issues that are around those. And then phase 2 is to use the outputs of phase 1 to inform our kind of future planning and improvement action, so that we hit the ground running for 24-25. I did reference an NHS England dental team. So prior to the delegations going live, there was a small team working across the West Midlands, hosted by NHS England. That team have been retained, and they will now be hosted by Birmingham and Solihull ICB, and we'll be working very closely with those colleagues to make sure we've got access to corporate memory, continuity of decision making, etc. I think it's fair to say, and I think the report shows this, that of the 3 areas we've inherited within the new delegations, dentistry will be the most challenging, not only in terms of the kind of long-standing factors that are impacting on operational performance. We've got the added impact of the pandemic. And from an ICB perspective, whilst we've taken on responsibility for operational performance, there are still a number of those challenges are at a national level and need to be resolved through national dialogue. So there's something of a mismatch between the powers and the responsibilities that the ICB has and some of the challenges that we see impacting on dental performance. We talk about some of those challenges, so recruitment and retention, and just simply the workforce numbers, the contractual environment. So the core contract for dentistry essentially is predominantly the same as the contract that was originally established in 2006, so nigh on 20 years ago. Now there have been some tweaks around the edges, but predominantly it is the same as the contract that was issued at that point, and that has a number of associated issues with it, not least of which the fact that the mechanism for commissioning dentistry is very different to what ICBs and CCGs before them would be used to. And as I say, we've not necessarily inherited a significant number of levers that we're able to adjust performance at local level. So the report does set out the level of operational performance at the moment. There's more work we need to do in terms of, as I say, going through that phase 1 process and understanding exactly the legacy we've inherited. But I think it's also true to say, and it would be wrong of me to suggest otherwise, that there is a protracted timeline over which we will be looking to improve. All of what I've said there is generally true of any ICB that's inherited dentistry. I think it's reasonably fair to say. Just a little bit more about the Staffordshire position. So within the delegations, about 168 dental practices. The vast majority of those are clustered around towns. So we know there's a kind of urban-rural access issue. There is already some evidence of health inequalities. So we know that those people who live in more deprived areas are attending NHS dentistry less than other groups. We know that the challenges in access is generating some demand that's presenting in other portals. So for example, we are above average in terms of our attends accident and emergency for dental reasons. But we also know that post-pandemic there is some signs of recovery. So as at May 2023, about 47% of the population had accessed NHS dentistry within the past 24 months, that compares with about 55% of the population pre-pandemic. And on current trends, we are due to recover to that position by January 2024. Although I think it's reasonably obvious to say as well that 55% of the population accessing dentistry is not where we'd need to be. But there is a period of time for us to recover to the pre-pandemic levels, and then we need to move on beyond there. There is a lot of variation in those headline figures, and the report that I referenced within phase 1 will help us examine that in more detail. We've received the first cut of that review in the past week or so. It stretches to 147 pages, so there's a period of time now that the ICB needs to consider that report, condense it and distill it, and then we can start to share in summary form some of the findings from that report, and then perhaps more importantly what it is we're going to do about the findings that are in there. So there's a bit of promise of jam tomorrow in there, Chair, for which apologies, but as I say, the report's in the pack, and happy to take questions and comments, recognising that I may need to take some away to West Midlands colleagues.
Thank you, Chris. So let me bring in Charlotte Atkins.
The Westminster Government says that the NHS dental service is on the road to recovery. So would you agree with that, with your limited experience of dental service? And of the 168 practices that you oversee, what percentage of those dental practices are still taking NHS patients? And in terms of the third question, and in terms of the those practices which are under-delivering, have you mapped those to see whether the practices which are under-delivering are in the more deprived areas? And if not, are you intending to do so? Thank you.
We're with you, Chris.
Yeah, so in terms of question 1 around recovery, I think, as I say, we are on the road to recovery to the pre-pandemic level. So the current trends suggest that by January 2024, we'll have recovered to the proportion of the population accessing NHS dentistry to be equivalent to that pre-pandemic. But I think, as I said, we don't think that that would be sufficient. So there's more work for us to do in that regard, and we'll be setting out those plans in the second half of 23-24 once we've had chance to review the report. In terms of proportions of practices accessing providing NHS dentistry, so I think there's a difference here between the theory and the practice, if I'm being completely honest. So what we know from our analysis is that of the 168 practices, 13% are fully private. So obviously that would then suggest that 87% are still open to NHS dentistry. But I think we'd recognise that the ability of patients to access that service doesn't reflect that. So there's more work for us to do in that respect. And then under delivery. So we do know that some practices have got the ability to deliver more NHS dentistry, but are constrained by the current contractual arrangements. And we know that some dentists are underperforming against the list. And I think within the report, we signal that in 2024, part of the reforms that are coming through does give ICBs the local power to be able to move that level of contracted activity around the dental practices, so that those practices who want to do more but are constrained by the contracted levels are able to do more. We need to be mindful within that, though, of course, that about the impact on local populations and kind of public transport routes, etc., to make sure that whilst we've at headline level may have commissioned dental activity, that it remains accessible by local communities.
I could come back, first of all, on the issue of the NHS dentistry. The question I asked was not how many are doing NHS dentistry, but how many are taking on new NHS patients, which is a totally different question, number one. And number two, I asked about the mapping of those dental practices which are underachieving, and does that match up with areas of deprivation, because the issue is that if people in areas of deprivation can't access dental care, then they're unlikely to be able to go down the private route or be bribed into going down the private route by their local dental practice. So that's what I wanted to know. And if you haven't mapped that, do you intend to map it, and when? Because it is urgent.
Thanks, Chris. With you.
Yeah, so I think within the answer I gave around the proportion of practices that are still taking on dentistry, I think I did acknowledge that we know that doesn't meet the experience of patients on the ground. So there is more work for us to do in terms of understanding which of those dental practices, which on the face of it have open NHS lists, are actually accepting patients. And there's as I say, once we've been able to consider the findings of the review, we'll be able to give a more fulsome answer to that. And then the question around the mapping is yes, absolutely. Again, we've not done that yet, but we will need to do that as part of that review, because I think I alluded to the fact that we do have some headline health inequalities, and that they are associated with areas of deprivation. So we do expect to see that variation in provision at for those more challenged areas, but we've not completed the mapping as of yet. That will be part of the phase 2 work that I referenced earlier.
Thanks for that. Chris, can you just put some dates to timelines to the 2 points that you made to Charlotte in response, please?
Yeah, certainly. So as I say, phase 1, we've received the first report around dentistry, so we'll need to consider that over the next few weeks. In terms of how we can then use that to inform future improvement activity, I think we'll be looking towards kind of September, October time by the time we're able to come back. Chair.
Thanks, that's helpful. Jill Hood.
Thank you, Chairman. I'm sure, Chris, that a 147-page report will be very interesting reading, and wonder how many nights you're going to be staying up reading that. My question for you, Chris, is that it used to be that when you had your NHS dentist, you would just naturally keep that dentist throughout your family's life, and as new children came into that family, that dentist would take on that child. Charlotte Atkins has spoken about areas of deprivation, and I'm asking you, I don't see any difference now between areas of deprivation and areas of people who are perhaps possibly able to afford a dentist. There's, wherever you call a dentist, their list is full, be it NHS or private. And I believe that there will be a tsunami of children soon that will be coming to the dental practices, and there will be no way that these children can be seen, which will then put a burden onto A&Es, because people will start taking their children to the A&Es. Can I ask, please, Chris, how do you see this playing out over the next few years? How is this actually going to be dealt with?
We're with you, Chris.
Yeah, so I think in response to a couple of those comments, I think we'd concur. I think we do, as we say, I think the point regarding access, health inequalities, and the link to areas of deprivation is established. We need to understand more about that, but I think at headline level it is established. We've also seen some signs that the average level of tooth decay or poor oral health in children under 12 is perhaps worse in Staffordshire than for the national average, which again plays to the councillor's point. I think, as I said earlier, the road to improvement is going to be a very protracted one, because a number of the issues that we're seeing in terms of the recruitment and the retention of dentists, the issues that are associated with the national contract, they're not necessarily in the sole control of the ICB to be able to respond to. So I think we will see a challenging position for for a protracted period. What we need to do in the meantime then is understand what improvement activities we can take locally. So as I say, moving commissioned activity around, but there are also other areas. So if you look in the north of Staffordshire, the University Hospital North Midlands has a programme called Keep Smiling, which reaches out into local schools to promote the benefits of positive oral health. Within the pack that we've made available to you today, we talk about a children's community dental service to support practice. So there are local actions we can take, but I don't want to overpromise and underdeliver in terms of the length of time that I think we'll see this improvement activity play out over, and indeed the ICB's the levers of change that the ICB have got available to it. We will see some challenges in provision for quite some time yet, I'm afraid.
Jill, do you want to come back?
Yes, thank you, Chairman. I would like to make a point, Chris. It's not a question that I'm dealing with families who, to afford a tube of toothpaste, would probably stop them being able to afford a very basic item of food. And it does worry me greatly that our children's teeth, within a few years, we are going to be seeing a pandemic of tooth decay. Thank you, Chris. Thank you, Chairman.
Richard Cox.
Thank you, Chairman. Chris, my question is around your national initiatives, and in bullet point 4 on the report, which says where dentists do not deliver as many units of dental activity as their contract allows, the funding for unused capacity may be, and I emphasise may be, transferred to other dental practices that can provide additional appointments. So I think from that, my question is what criteria do you work with to obviously for that transfer, and what dental practices are able to actually manage it? And if, for example, then funding is left in the pot, what exactly are you doing? Because it's not going to necessarily solve the problem of our dental situations. You know, obviously we know that we've also got the additional development and new housing and everything else, and it's all about locality of nearer people want dentists really near to where they live. And retiring dentists, you know, what is the way of replacing them in the areas that are being lost due to perhaps retirement? So I don't know whether you're able to answer those, Chris, but to me I think it's fundamental in the process of dental care. Chris, we're with you.
Yes, it's perhaps worth saying that within the so I keep mentioning this review, so that's been commissioned by each of the ICBs within the West Midlands area to give each of those ICB areas a more in-depth understanding of the challenges in its area, and there'll also be a summer workshop that's coordinated by that. So again, I think that just kind of builds a picture that our understanding of the issues will develop over the kind of the first half of this year, and perhaps, Chair, if we come back kind of October time, we'll be able to give a more fulsome update. In relation to the two questions there around contracted activity, so the way in which dental activity is commissioned is very different from the way in which general practice activity is commissioned. So each dentist is commissioned to deliver a certain level of activity. They're called units of dental activity, and once those there are some practices, for the reasons that we've talked about, who do not achieve those contracted levels. Hitherto, it's been quite difficult for local commissioners to move that kind of surfeit of contracted activity across different providers. That is part of the changes that are coming online in 2024. We have already done it actually in relation to a dental practice in Tamworth, but that was a practice that had signalled to us it was going to hand its entire NHS contract back, and we wanted to make sure there was continuity of service provision for the people of Tamworth. So there are actions we can take. In terms of the criteria, there are two really. One is where we have a dental practice signalling that they will not fill their quota of contracted activity, we then need to understand what the area in which that dental practice sits, whether there are any surrounding practices that would either A, be willing to take that contracted activity on, because we'd be asking that practice to deliver more NHS service, and that practice would need to consider what that meant for that individual practice relative to other work that they were delivering, and B, the access, by which I mean kind of transport and so on, access to alternative dental practice provision, so that we were able to maintain the provision within that local community. So hopefully that answers the kind of criteria question. In relation to workforce, again, I think the council's right to highlight it as an issue. I think we've highlighted it in the pack. There is a national constraint on the number of dental practice placements that are available in terms of people who want to study and qualify to be a dentist. That's not a challenge that the ICB in and of itself can respond to. We are working with other partners in terms of options that may be available, and part of the reinvestment opportunity may well be to work with dentists who may want to retire and return, so that we're able to offer some degree of continuity, as well as provide incentives to deliver more NHS dentistry. So it's a mixed picture, I think is what I'd say in the first instance, but we do need to be working with partners across the West Midlands and indeed nationally on some of the challenges around the recruitment and retention issues.
Richard?
Thank you, Chairman.
And Angela?
Thank you, Chairman, and thank you, Chris, for your presentation. All right, we all know healthy teeth is so important to good health. My question relates to, on the agenda on page 12 of our agenda, about a third of the way down, it says dissatisfaction with the dental contract. So some of these NHS people, if some of these private dentists that are not picking up on this NHS contract, what is the reason? What's the problem with the contract that they're not happy with? Please, thank you.
Chris, we're with you.
Yep. So I think there are, as I say, the way in which dental services are commissioned is very different from general practice. So in 2006, there was a new national dental contract, which, as I say, has had some tweaks over time, but the core provisions of the current dental contracts remain rooted in that 2006 change. And that, as I say, means that dentists are then commissioned to deliver units of dental activity, and they are banded over different courses of treatment. So band 1, 2, 3 to represent different levels of complexity within the treatment. And each one of those essentially generates a different weighting of UDA activity to be called off the commissioned level. I think the issues that we see are that the frustrations, as I understand it, from dentist colleagues are that the way in which that service is commissioned is focused on treatment. It doesn't particularly provide any incentive for prevention. There's no payment essentially for going above the contracted level. So once you've delivered your quota of units of dental activity, there's no kind of auto provision to go beyond that, which, as I say, then means that some dentists could deliver more. Some dentists do not deliver the quota, and we've got the challenge of being able to move that activity around in the way that I described to Councillor Cox's question. And then I think there's a challenge from NHS dentists about whether the level of payment within the national contract reflects the cost of providing that service. So there are a number of issues associated with the contract. We do understand there will be a major review of the national contract in 2024. But if I'm being completely honest, I think we've heard that a few times previously across the life of the contract, and for various reasons, it's not manifested itself in any significant change. Although there have been tweaks, as I say, but we are understanding that there will be a major review of the national contract as it currently stands.
Anne?
Yes, thank you for that. I think it's something we need to keep our eye on. Thank you, Chairman.
Thanks, Keith Flunder.
Thank you, Chair. Yes, I think you've already answered some questions I was going to have around children's schools and also timescale, so thank you for that. My issue at the moment is I'm sure it's early days as well for you, so you may not know all the details, but the corporate dental contracts and other dental contracts, there's quite a variation there in terms of delivery and the skill of that delivery. I don't know whether you've got any idea about why that is, because obviously I was assuming that the corporate dental contracts you've got more control over to some extent, unless that's just because the rooms within the facilities there are within your remit. I don't know if you can try and explain that a bit. And then secondly, in terms of obviously when you're looking at restructuring and everything else, and it hasn't been mentioned, Matt, is the emergency dentistry cover, because I've had experience of not being able to access that at all. And of course, people can be in a lot of pain, particularly if they've tried to take their own teeth out with their own pliers. And it's the idea of having some emergency cover rather than necessarily blocking up what's going to be happening. And I'm sure it's later in the agenda as well, all the other services that are happening at A&E. So just those two at the moment. Thank you.
Chris?
Yeah, both of which will be covered within the improvement plan that we develop in the second half of the year. But just some early thoughts, so I don't avoid the question completely. First is that we do know that what we call corporate dentistry, so by which we mean dentistry provided by multi-site organisations, as opposed to kind of quote unquote high street dentistry. We do know there is variation, so we see less delivery of NHS dental services through those corporate contracts than individually owned dental practices. We don't have any more or less control over those corporate contracts than we do with the other contracts. They're all kind of treated the same way. Our working hypothesis, and I'll stress it's a working hypothesis, is that within servicing those dental contracts, as I say, they're kind of multi-site. So you may see some dentists moved around those sites to be able to serve in different locations, which often means that there's a downward pressure on access in some parts. So we need to understand that in a bit more. And then again, urgent care, I think the point's well made. I think we'd recognise that access to urgent dental care is a challenge, and that oftentimes people are asked to travel a reasonable distance in order to access urgent dental care. And as I said in my kind of introductory remarks, we do know that for Staffordshire and Stoke-on-Trent, we do have above average attendances at our emergency portal, so accident and emergencies, for example, for people presenting with dental pain. So it is an issue that we're cited on. Again, will be covered in the improvement plan that we bring back.
Thank you, Keith.
Thank you, Chair. Yeah, I mean, obviously, I did see within the report as well the idea of looking at weekends, whether that's both for emergency and for normal dental practice, to try and increase and improve the access. So I look forward to your report. I don't expect you to come back and tell us all the details of that at this moment, but I think that's going to be in October, so I look forward to seeing it then. Thank you.
Thank you, Keith. Janice.
Thank you very much, Chair. I think my question originally, which was about the contract side, I think has been covered, and certainly in terms of what's due to come in 2024, I think just in essence is that those changes, do you think that's going to deliver what is needed? And your anticipation for those is a cover-all question, what I would do. And then secondly, orthodontics. So we've mentioned quite a bit about children, and obviously there's some time sensitivity to the delivery of orthodontistry. if there's some capacity for that when that's been identified. Thank you.
Chris.
Yeah, so I'll take them in reverse order. So orthodontics is one area that I will need to come back on, if that's okay. Colleagues in the West Midlands dental team would know the answer to that much better than I. So I'll perhaps take that one away. In terms of, do we have confidence that the actions in the from 2024 will deliver improvement? I mean, I think I've continued to say that we know this is going to play out over a protracted time period. The challenges around NHS dentistry are long-standing. Recruitment and retention challenges often take a degree of time to respond to. So I think there is work we can do and improvements we can make beyond the natural recovery to the pre-pandemic levels that we're expecting to see in the early part of 2024. So I think there's certainly work we can do to enhance increased performance above that level. I do think, though, we will need to see the output from the national review of the contract before we can commit to any greater level of performance recovery above what we'd expect to see in the natural course of events.
Janice.
Thank you. Yeah, thanks for that. And to be honest, I think I probably share your honesty there as well in terms of what we can expect. But equally, I think making sure that we've got a role to play in what we want it to deliver, and especially for the residents in the area. I'll await the reply for the orthodontics because that is a treatment that is provided up until a certain age. Knowing that we've come from a period of time when we couldn't access dental treatment, I think that is a particularly important one to try and get a good picture of those. So I'll await that one. Thank you.
Thanks for that. And I think, Chris, just following on Janice's question, can you just make sure that the secondary point that Janice makes in terms of, the impact from COVID is also covered within the response, please? Philip Atkins.
Thanks, Chairman. We're very much an overview and scrutiny committee, and you've been scrutinising current situation, and you did mention it in one of your answers. The short, medium, longer term is pretty basic. That we need more dentists. There's only one dental school in the West Midlands. That's in Birmingham, and so a direct question, really. I was involved with the new vet school early on in Keele because there's a shortage of vets, and I voiced this at Keele. And it's, would you support a new dental school at Keele University?
Very direct question, and I like those. Very incisive as well. And you asked a question I was going to ask, which is, where's the nearest dental school? So thank you for that, Philip. Chris, we're with you. I've given you a couple of seconds to think about your answer.
Yeah, so it is absolutely true to say that the nearest dental school is in Birmingham. I think it's right to say, don't quote me on the specifics, but I think there's only been 2 new dental schools opened in many decades, in fact across England, which shows perhaps why we've got some of the challenges we've got in terms of workforce numbers. It's very, very early in the conversation, but there has been an exploratory conversation with colleagues at Keele about the possibility of a dental school. That was a conversation facilitated by Jack Brereton MP and Aaron Bell MP, with colleagues, executive level leadership within the ICB and Keele. There is a follow-up conversation later in July, but I would stress that they're very exploratory at this stage, but it is an avenue that we're working on.
So you heard it first. Philip, with you.
Yeah, Chair, don't be deterred. The vet school was exactly the same argument. We haven't opened one for donkey's years, and et cetera, et cetera. One of the things about Keele is it already has, and the vet school costs £35 million, and a dental school would probably cost about the same if it was starting from a bare facility. And there's sites up there. They've already got the medical centres and schools up there, so I reckon you could probably trim 10 million off the cost. I know the astronomical figures, but I think it's an ideal place, well suited to serve the North West, the Midlands and the East Midlands, with some better transport links, Chairman.
Thank you. And Staffordshire is very firmly open for business. I think that was the message from Philip there, Chris. Is there anything further you want to just answer on that, Chris, or add?
No, I think, as I say, Chair, it's very, very early stages of that conversation.
Can I come back, Chairman, and say, please, would you like the support of this committee?
I think that was a very direct question. Would you like, Chris, the support of this committee?
I'm more than happy to receive the support of the committee. As I say, the introductory conversations were facilitated through two MPs. More than happy to have the support of this committee to add weight to that as well, yeah.
Is that a proposal? Well, it's a proposal on the floor. It's
a proposal, Chairman.
Is it seconded? Are we in favour of the committee writing to presumably the ICB in Kiel? Is that? Yeah. Okay, thank you. So let me just summarise the discussion as I think we've debated the issues as we see them, which I think are about uneven access. It's about residents being able to look after their own dental health. It's about whether the NHS contract for dentistry is fit for purpose, and then equally whether it allows for the shortfall in hours to be picked up. We're clear, thank you, Chris, that there is work already ongoing within the West Midlands area to look at gaps in provision, and that that information will be available from June for your analysis. And I think the suggestion from committee is to look at the strategy that comes from it, the gaps in provision and what you plan to do to close some of those gaps later in the year, September, October time. Is that a proposal that we're happy to work to? Thank you. So appreciate the work that you're doing, but equally appreciate how far back we are, because I noticed that you're only comparing to pre-pandemic periods rather than necessary to 100% perfect oral hygiene and health. So I'm going to suggest that we look at this within our section on planning for the future agendas. Thank you. So that brings us on to primary care access. We're still with you, I believe, Chris, and with colleagues. Paddy, good morning.
Morning.
Yeah, so I think I'm listed on the agenda, Chair. I think we thought, just to break up the delivery somewhat, that Paddy would lead out for us on this, if that's okay.
Perfect.
Chair, would you be happy if I showed a set of slides to illustrate the papers that have been presented?
Yeah, please.
Just, are those visible?
It's thinking about it. It's coming.
Good. In anticipation, I'll start. So thank you. I'm Dr. Paddy Hannigan. I'm a GP in Stafford, and I'm the clinical director for the primary care portfolio within the ICS. Thank you for the second invitation to talk about general practice. We came in the spring and presented the strategy for general practice in the ICS. And we're asked to return to talk a little bit more about primary care or general practice access in particular. This is timely because nationally a significant document has come out, which is the delivery plan for recovery of general practice access, which describes the NHS response in England to the access issue. And in that is a significant refocusing of financial resource to meet this particular problem in the next year. And much of what we present today fits with that national plan. I think the slides on the screen now.
Paddy, we've lost the slides this end.
Okay.
We did have them for a minute and they've just gone again.
I'll try again. Is that showing?
We've got them again.
Right, I'll carry on. A little bit of context. There are 142 GP practices in Staffordshire and Stoke-on-Trent, and we're currently offering significantly more appointments than we were pre-COVID. That's two parts of the NHS are currently have recovered pre-pandemic activity. One is cancer care and the other is general practice. And we're currently, in the last year, done about 11% more activity than in 1920. And that actually equates to just under 6 million appointments in general practice in the last 12 months, which is just over 5 per citizen in Staffordshire. 47% of those booked on the same day. That doesn't necessarily mean that they're all, in inverted commas, urgent, but about half of our work is booked on the same day. And in the last year, about 74% of those appointments are delivered face-to-face, and that's probably higher than national. About 7% or 70% of our practices are conducting more face-to-face consultations than they are nationally. It was about 10% lower last year, so that's been a sort of steady recovery. We've always done a lot of work on the telephone, and that sort of 3/4, 1/4 split is probably where we were pre-pandemic. Satisfaction rates in general practice have fallen very significantly from pre-pandemic. This set of next two slides basically shows the national GP patient survey, which is conducted across the whole of England annually, published in July each year, and it's done in the early spring. We're just awaiting this year's report, but over the last 3 years, there's been a steady reduction in the three sort of what we deem to be the sort of headline numbers around people's experience of booking appointments. So how easy is it to get through on the phone, the experience of making the appointment. So you'll see from the figures, about half of patients find both of those satisfactory, but a significant proportion, particularly half of patients are finding it not easy to get through on the phone, and just under 30% are reporting a poor experience of making an appointment. Our figures are similar to slightly below national figures, and the third slide, or the second slide of this pair shows the overall experience of general practice, which is actually reasonably high. So the message is getting through on the phone is difficult. The experience of making an appointment is not good for a significant proportion of patients. But once patients get in front of a clinician, they're pretty happy, and that again is fairly similar to national figures. The workforce in general practice has been changing. Again, this is part of the context we're working with at the moment. There's been consistent workforce pressures in general practice and primary care for a number of years now, and probably exacerbated by the pandemic. The number of qualified GPs per 100,000 patients has been slowly and steadily falling. It's gone down from 47 per 100,000 to 44 per 100,000. That's national, and it's also our local experience. We're losing GPs. We're particularly losing GP partners, and that partnership model is more rapidly eroding. There's been an increasing number of salaried GPs, but overall the number is reduced. The national response to this has been to create a new workforce in general practice. We refer to them as the ARS roles, the Additional Role Reimbursement Scheme. And the ambition up until this year was to create 26,000 new posts across England. And there's a significant reduction, so a significant increase in that going forward this year, with a significant increase in funding. And there are now 17 different roles that can be employed under the ARS process. People will recognise some of those things like advanced nurse practitioners, paramedics, physician's assistants, but it also includes clinical pharmacists, pharmacy technicians, people who are involved in care navigation and GP assistants. It's quite a range of different staff now. And the R's roles have their portion of the GP total workforce has risen from about 8% up to about 16% last year. So there's a significant workforce changing happening in response to that erosion of the number of GPs. The other thing that's happening, of course, is that we are facing increasing pressure and demand for capacity in general practice and primary care more broadly. That is particularly driven by demographics. It's the rising population. It's the rising proportion of elderly patients. It's the rising number of people who have multiple term conditions. And so the demand for appointments, prescriptions, treatments has been steadily rising. We've also seen an increased number of administrative and other tasks generated by secondary care, and particularly the elective backlogs are driving patients back through general practice whilst they wait for secondary care procedures and treatments. There's been probably a lesser effect of the vaccination program. For a couple of years, we had a lot of activity through general practice supporting the COVID vaccination program. That is reducing as the vaccination program has been reducing. And also there's still a sort of degree of pent-up demand generated from the pandemic, particularly around the management of long-term conditions and the sort of annual reviews and issues that were postponed during COVID. There's also a continued sort of language problem. I think everybody from the media and the politicians down through ourselves to the public talks about making an appointment with a GP. And as I've demonstrated, that the workforce in general practice is now increasingly non-GP care providers, and that language hasn't really changed. Got two slides here which I think illustrate the issue, one of the issues we're trying to tackle and one of the solutions. The language in the slide isn't of my choice, and I'll qualify a little bit of the language. But it's a piece of work done in London, South Bank University. One of the ICSs there commissioned some work with general practice to look at demand and capacity, because there's a big feeling that we haven't got the demand capacity equation right. So the bar on the left shows that 85% of patients get the appointment that they want, albeit their experience of doing that is probably not as good as it could be. And there's a level of unmet demand, patients who cannot get seen, and they estimated from the work they did in London that was about 15%. So 15% unmet demand. On the other side, on the flip side, they work with the GPs to look at what they were seeing in their consultations to say, were you the right person to solve this problem? And they've labelled this as inappropriate. I think inappropriate isn't probably the language we would have chosen. And in previous studies, they've used the language of was there somebody who would have been as able or better to resolve the problem other than a GP? But the figures actually show from this work about 40% of the people seeing GPs could have had their problem resolved elsewhere or by somebody else. And that potentially is one of our solutions. The current capacity issue is to identify the reasons that people are coming to see GPs and try and route them to another place or another person who can resolve the problem for them. This is a little bit more work which just shows how that breaks down. And actually the biggest group of that are other staff, those R's roles within the practices, but it also includes community pharmacy, administrative tasks like sick notes and services outside the practice. So there's a whole range of different ways to get problems solved rather than seeing a GP. This piece of work actually fits very, very neatly with other work that has been done pre-pandemic, which again came up with a figure between 25 and 30% of GP appointments could have been dealt with in another way. So the national plan for recovery has a number of elements to it, but one of the elements is to try and improve the experience of booking appointments, and particularly what people recognise and describe as the 8 a.m. rush, where everybody is trying to get through on the phone at the same time. As I showed earlier, about 85% of people will end up in the right place, but their experience of getting that is not good. So a number of strands to this. One is to try and get cloud telephony used across general practice. At the moment, we have a mixture of analog and cloud-based telephony. Cloud-based telephony allows things like callback facilities. So rather than sitting holding for 30 minutes, you can log a callback and be called back later in the day. But it also allows calls to be routed to call centres or messaging on phone lines to be changed at different periods in the day. So a better telephone experience is one of the pieces of work we're focusing on. The other one is digital and online requests, and some of you may have experienced this in your own practices, where practices are increasingly asking patients to give information online as a way of allowing the practices to sift out, as I showed on the previous slide, sift out patients who could have their problem resolved without booking a GP appointment. This also serves to smooth those requests away from the 8 a.m. rush and spread them throughout the day, and practices are able to work away at patient requests through the whole working day, rather than trying to deal with them all in the first hour of the morning. My practice has introduced this recently, and we're taking about 100 telephone or online requests a day for how can I get this problem solved, or can I get a fit note, or things that would have come up over the phone, and that frees up our phone lines to allow us to speak to the people who don't have digital or online access, and again gives a better experience. The key to all of this working is what we describe as care navigation and signposting, that ability to move from a conversation about I want to book an appointment with a GP to what is the problem you want us to resolve for you, so that we can correctly and quickly route patients to the best person in the best place to resolve the problem. That's sort of fundamental to how this is going to work moving forward. So we need to make better use of that wider workforce, and we need equally to improve the experience of our current staff, because as much as this is currently difficult for patients, it's equally difficult for the clinical and admin staff in general practice who are having as poor an experience as patients at the moment. So the national work also includes a reduction in bureaucracy. About 10 to 20% of general practice time is taken up managing admin issues, and often those are generated in the interface between sort of general practice and other services, described as a primary secondary care interface. The ICS, through our clinical senate, has already sponsored a document about improving the primary care and secondary care interface, and we plan to set up we already have some meetings between secondary care and primary care to try and manage operational issues. We also need to work on direct access to services, so the general practice doesn't become the gatekeeper to everything. There are a lot of services where patients could directly approach the service for care, and things like audiology, physiotherapy, and a number of other areas where the GP doesn't need to be the middleman. Things like referrals from optometrists into ophthalmology currently get routed through general practice, and there are IT solutions out there which will allow us to connect optometry directly to ophthalmology and cut out general practice. Also, our increasing ability to use data across the ICS means that services can directly recruit patients, because we now have an integrated care record across the whole of the NHS and local authorities to allow us to share information about patients. And that it should be a prelude to services being able to directly recruit patients in, rather than requiring GPs to refer everybody into services. Nationally, there's also a large piece of work on reducing bureaucracy, what's called a bureaucracy busting concordat. So the ICS primary care team is organised around the delivery of both our primary care strategy, within that the fuller stock take piece of work that we presented the last time we presented, and also this access piece. And we have a wide range of programmes to focus on the different elements that I've described here. And we have a number of challenges, particularly locally around GP and particularly GP nursing retention and recruitment. We also have an interesting phenomenon where we're actually providing a sort of lower than average number of appointments per 100,000 or per 10,000 patients compared both regionally and nationally. Something we're trying to understand at the moment, and we're doing quite a lot of work around the complexities of how general practice records their activity. We think there's quite a lot of hidden activity that isn't being recorded through the appointment system, and part of the national programme and our own local programme is to improve that over the next year. We also mentioned the R's roles. We also underspent the available budget by about 20% last year, which is about £4 million, and actually had the largest underspend on the R's budget of any ICS. Lots of reasons for that, related to particularly recruitment, retention, and assimilation of new roles, but also final bullet is our general practice estate, because obviously this wider workforce is going to require probably more estate or different use of our current estate. So there's a challenge, and again a programme of work around how we improve that. So that's a counter through the national and our local plans to improve primary care or general practice access. As I said, the public experience of general practice has nosedived over recent years, and the British Social Attitudes Survey had previously rated general practice as amongst the most popular parts of the NHS, and last year it had sunk to the second lowest, the lowest being dentistry, which you've just discussed. So recognised as a national problem, and if patients are consulted and have been consulted on their top priorities for the NHS, access to GP appointments came out top of the list, with 48% of the population saying that that was their primary concern around the NHS. Thank you, Chair.
Thank you. Let me bring in Angela, please.
Thank you very much, Chairman, and thank you, Paddy, for your, although I couldn't read all the slides actually, but that's by the by. With the rising population in Staffordshire, my question really relates to what interaction do you have with planning departments throughout the boroughs in Staffordshire? We're told, you know, especially with the large developments, do you get involved in being asked whether we should have increase in a doctor's surgery? I mean, we're told on planning that unless it's over 500 houses, you don't get involved. Is that correct? And what interaction do you have so we can help the people with GP access? Thank you.
We're obviously straying slightly into the territory of the estates, but there is a crossover between the two, so I think it's fair. But let's not try and cover the next item first, please. Paddy, can I leave that with you?
Yeah, I was going to say the best person to answer that would be Andy, who's on the next part of the call. What I will say is that we have, and Andy will probably pick this up later, is that we do have close involvement with planning around developments and changing population size. We have a sort of ongoing dialogue. I would say that we don't necessarily want to build more GP surgeries. I think our planning is bringing up the standard of a lot of the state we currently have. And actually having more practices. We have 142 at the moment, and actually it's been a slow and steady reduction. So we're seeing single-handed practices merging. We're seeing practices which are struggling merging, and so our main issue is about building resilience, not necessarily building more. And as I've described that sort of wider workforce, there is something around the workforce plan that probably wants a sort of increasing scale rather than increasing number. But Andy can talk more about how we work with planning.
Do you want to come back, Anne, but don't stray into
with
the
another
next...
question, actually. Thank you. Paddy, you do know, and I won't mention any which surgery it is, but they've done a contract with UHNM, and from that, I actually got an appointment on a Sunday, which I was quite surprised about. But could you explain to the committee about this contract and how it works? Thank you.
There's a number of different contractual models for general practice. I mean, as I said, we've got 142 practices. The majority of them still are still what we could describe as general medical services or GMS contracts. So they're individual practices working on their own. We now have some multi-practices where we have several practices working together with a single management team, and we also now have a small number of vertically integrated practices that are working with one of the other providers, in our case North Staffordshire Combined Healthcare, who currently runs 3 general practices. We also had one practice in the southwest that was integrated with Royal Wolves for a period of time. They've decided to leave that agreement. The Sunday services, I mean, we have what's called extended access, which is a whole national program which all practices provide, usually at primary care network levels. They're not usually providing it themselves, and they provide appointments in the evening on Saturdays and Sundays, and that's available across the whole of Staffordshire. The general practice element at UHNM is the sort of GP front door, which is a sort of slightly separate scheme, which is around providing sort of primary care input to UHNM's A&E urgent care portal, and allows them to filter out some of the primary care work into a sort of general practice level of care, and that's provided by the North Staffordshire Federation at the moment.
And do you want to come back?
Thank you, Chairman. No, thank you.
I just want to ask a supplementary on Anne's behalf then. There's clearly other models of GP practices. I mean, I'm aware that, for example, Royal Wolverhampton Trust have got 17, I think, employed GP practices. What is your analysis of alternative models, and what is your preference in terms of the future going forwards?
So this is a subject to a national political debate, and at times our previous Health Secretary, Stafford Javid, did suggest a change from the current GMS contractual basis into a fully salaried service. The Shadow Health Minister has equally suggested that at times, although he seems to have rolled back. I think from an ICS and primary care team perspective, we are less concerned about the contractual model that's used going forward. And in fact, we talk with our practices around, accepting a plural model. It doesn't matter to us what contractual form practices choose for themselves. What we're interested in is the quality of the services they provided, probably their CQC registration, and how they've scored through the CQC. We're concerned about their resilience and their ability to manage the sort of changing dynamics, particularly this change in workforce. So as I said earlier, there has been a sort of steady reduction in the number of practices. That's not a policy of ours, but we as practices get into difficulties, we try and support them. But where they're stuck in that difficulty, we then look at mergers and different routes to support them. So our interest is not the contractual model; it's the resilience and quality that the practices provide. And I think as an ICS, we'd very much want to support anything that practices choose, as long as it provides both of those.
Chris, can I bring you in?
Yeah, just to say, absolutely echo that. I think the kind of headline for us would be what matters is what works, rather than the contract model. And we have several conversations with GP colleagues to that effect. So vertical integration, the GP partnership model, PCNs working better together, all of those things are permissible from our perspective. It's perhaps just worth saying that for those practices who did want to vertically integrate with another NHS provider, so whether that's Royal Wolves or North Staffordshire Combined Healthcare, that the ICB has inherited the CCG's responsibility as the kind of local commissioner for services. So any proposal would need to be made to and supported by the ICB in that regard. So there are some kind of checks and balances in that. But Paddy's absolutely right in terms of the kind of general messaging.
Thank you. I'll come back to that, but let's bring in Bernard Peters, please.
Thank you, Chair. An observation, if I may, in this transition to expanding community pharmacies, what residents in my division are telling me now is that you're number 58 in the queue when you ring the GP. You don't get that message at the pharmacy. The phone just rings out for in excess of 20 or 30 minutes, which is a frustration. So there's something there about the way they're going to deal with any expansion in volume and workload. And just to supplement that as well, I've observed when I've been to the pharmacy recently that they seem to, because of the volume and people turning up there now, that their stock levels are usually not sufficient to deliver on the day. And people who may not have the best of mobility are being asked to come back in a week, in 2 days. So there's a big piece of work, I would suggest, around how you're going to engage with the community if you're going to increase the load on pharmacies. Is there a view on that, please?
Thank you, Bernard. Paddy?
Yes, I mean, I think there's probably two separate strands to that question. I mean, the first is around the expanding role of community pharmacy, which, interestingly, there's been a scheme running for a year or two now called the CPCS scheme, the Community Pharmacy Consultation Scheme. And Staffordshire and Stoke-on-Trent are one of the highest providers of that. Our community pharmacy have been very active in that space. And what happens is, again, in that sort of request that often comes into general practice to resolve a problem, is that the GPs can directly book them a return call from their community pharmacy, and that's done online. And it's one of the mechanisms where general practice can route patients through to an alternate provider who, if it's a medicines query, community pharmacy are often better placed to answer the queries and questions that come up. The national scheme, whilst it's being talked about, is talking about the pharmacies providing probably about 3% of the capacity that primary care provides. So or an increase in 3%. So it's not. The ask isn't a huge ask, but yes, it is pressure, and community pharmacy, in the same way that dentistry and general practice are going through this sort of particular problem around the national contracts. It's fair to say that the national contracts across all three of those areas of primary care are due for review, and some of the current problems we have are because the current contract hasn't quite kept up with the intention around how the services are going to work moving forward. And I think all three are slated for reviews over the next couple of years, again tempered by Chris's earlier comment on dentistry, in that timescale may be fluid, but I think there's a recognition that the contractual models haven't quite kept up with the ability to deliver exactly what we want to do. The issue about medicine supply is an issue of its own, and it's a massive frustration for patients, community pharmacists, GPs. We're all suffering the brunt of that. I mean, I've been a GP for so long. It's sort of, it didn't never seem to be a problem like this. But the number of times we have patients who cannot get the drugs that we prescribe because they're not available has gone steadily up over a number of years. And this is before COVID, but it's sort of continued since. And it's a whole range of things. It's a thing of huge complexity. It's about supply chains. It's about ingredients. It's around the manufacturing market internationally and nationally. It's about distribution and supplier chains. The net effect is that the number of drugs that are temporarily unavailable is really quite large now, and they come and go, and so patients and GPs are and pharmacies are having to struggle with this issue of something just not being on the shelf, of having to come up with an alternative, or patients having to come back, and it's a huge inefficiency. And I don't think it's a local issue; it's a national and international issue.
Bernard?
One point, if I may. A pharmacist will only provide the drugs or the medication that's on the prescription. Now, if the pharmacist recognises now that that tablet or that pill or that gel is no longer available, the patient is advised to go back to the GP to get another prescription, another step, another journey. So is there any flexibility in the new model that we'll be talking about, where a pharmacist can say, well, this is identical, it's just a different manufacturer, and we'll give it you in as an alternative to the prescribed medication? Because that really is a stopstone at the moment.
Absolutely agree. So there is some facility. I mean, most medicines are prescribed generically, not by brands. There's quite a lot of flexibility of providing different brands from different manufacturers. There are some abilities by agreement for pharmacists to make changes. We saw a lot of this around Christmas when we had a huge issue with the outbreak of Streptococcus A, and we had shortages across a wide range of antibiotics, and quite quickly there was a sort of national agreement for flexibility for pharmacists to be able to supply an alternative without going back to the GP, which was very helpful. There have been similar issues with HRT products for a couple of years, and there has been some local and national flexibility around that. The issues and the legalities around prescribing and the ability for people to change is reasonably restrictive for a whole variety of reasons. But I think there is a recognition that whilst we're in this current situation, giving pharmacists more flexibility to make changes is in everybody's interest. So again, we work fairly closely with our medicines team work very closely with the local pharmaceutical committee and represent these problems nationally. And as I say, there have been temporary and sometimes permanent national agreements around this flexibility. But it's difficult because sometimes there is something that just isn't available and there isn't a suitable alternative. So it can be quite tricky.
Thank you for that full answer. So let me bring in John James. Welcome.
Thank you, Chair, and thank you, Dr. Hannigan, for your presentation. I've got just 3 little points. You say in your presentation more appointments, and that looks really good. I mean, its percentage is up quite well. But how many of those actually are with GPs? You say yourself that the number of practitioner staff has doubled. Now, there's nothing wrong with practitioners, and I'll say that as recently until retiring, I was one myself. But you say in your own presentation, most patients do want to see a GP. So that's the first one. With regard to the National Delivery Plan improvements, you say more digital tech, better telephones, simpler online access, faster navigation. There's nothing in there about extra GPs. Isn't this diluting the service? It seems to me that sort of delivery plan should be a temporary with a longer ambition to get more GPs in post. And with the pharmacies, just to pick up on the pharmacy point that was made across the way there, I think there's a deficiency there in training and both infrastructure. There's no privacy in pharmacies. I stood behind some poor chap the other day in a pharmacy. I was waiting for a prescription where he was forced to list off a list of symptoms in a crowded shop. Quite embarrassingly, and to be told at the end of it, oh, you better see your GP. Good luck with that. So I think there's some attention needed to pharmacies, particularly perhaps the more mature ones that haven't been used to doing this type of work. And I just wondered if that was in the plan. Thank you. Thank you, Chair.
Thanks. We're with you, Paddy.
Yeah, I think if there's probably a sort of headline takeaway message from this presentation is we need to change that language, and we need to change that interaction with general practice and its whole away from I want to book an appointment with a GP to how can I best have my problem resolved? I think there's a fairly interesting presentation on general practice workforce that's done every year by a group called the Health Foundation, and they have projected both the rising demand, which is going to, where the baby boom generation is driving general practice and health service demand, and will continue to do so for some time. The rise in long-term conditions and the rising population, so the demand rise is locked in, and we have to build capacity. But if you look at GP training and workforce, that isn't going to give us an immediate solution to this. In fact, the ability to recruit and retain GPs is only going to partially meet that demand. So the Health Foundation piece had a sort of their projection based on current government policy would be that we would have a shortfall of about 25% in the GP and GP nursing workforce by 2030. If we don't do anything. Their pessimistic suggestion that we would have a deficit of about 50% in the GP and GP nursing workforce. Their most optimistic assessment was that we could meet the capacity rise, but only by using this R's model, this wider workforce. So I think the idea that we're going to be able to recruit enough GPs to go back to the way we were doing things in the next 10 years is not going to happen. We just, the lead-in time from medical school to training is so long that is not going to, the next decade, going to answer the problem. The solution is going to be building that broader, wider workforce, getting better at signposting people to the right person in the right place at the right time to best resolve their problem. But I think we've got to change this language away from, I want to book a GP appointment. On the pharmacy consultation, I absolutely recognise what you're saying. A lot of pharmacies are relatively small. We have a pharmacy next to my building where I'm sitting today. They have a consultation room. They can take people away from the front desk and have a proper consultation in private. Not all pharmacy has the space to do that. But certainly, part of that sort of whole community pharmacy consultation scheme is to try and build that capacity. And in the same way, we're about to talk about estates. It's a factor for pharmacy as much as it's a factor for general practice. If we're going to change the way different elements work, then we need to remodel some of the physical estate and some of the ways that we work. But it's I think that sort of model is here to stay, and it's part of that building that broader capacity base that we need.
Yeah, if I may, I broke it. If I may, Chair. I think that's fine. I fully accept what you've said, Doctor. It's just I was concerned there was no mention of increasing GPs in your presentation, and I hope that is still an ambition to get more, because we certainly do need some more. As I say, clinical practitioners, I have no issues with them at all, but people do want to see a GP, particularly what you call the baby boomer generation, my generation, want to see a GP most of the time. And with the pharmacies, I think it is a training issue with some. I think they're not used to doing that type of consultative work. It's just pills over the counter, dispensing pills over the counter. Not just, it's an important job. But I think they need to get some, there needs to be a little bit of training out there to reinforce the fact that people do need a measure of privacy and confidentiality when they're talking about symptoms, not just doing it in an open shop full of people. Well, thank you for that, Doc. Thank you very much.
Just thanks. Just on that, then, Paddy, can you just give some comments, first of all, to how we keep more of Staffordshire's trained GPs in Staffordshire? That would seem to be a relevant point from what was raised. I don't think it takes us back to what Philip was going to talk about, which was Keele University. But the other bit to it was just in terms of maybe with the community pharmacies playing a slightly different role, do they have better layouts that allow for patient confidentiality and privacy?
Yeah, I mean, recruitment and retention of GPs is a prime focus of us. For us, we've established a workforce implementation group to address general practice and primary care workforce specifically. Obviously, the ICS has a whole people program, but we've set up and started running our own GP primary care focused piece of work. There are a vast number of schemes, both nationally, locally, around this. There's a number of different dynamics. I mean, there has been a reduction in the number of people leaving medical school who have chosen general practice over a number of years. There has been a increasing number of people who have apparently reduced their hours, and that's a controversial way of putting that because the hours are still long. There are a lot of people who have are dropping out. There was some statistic a few years ago saying that about a third of young female GPs were dropping out within 5 or 10 years of going into general practice for all sorts of reasons. And then we've had this phenomenon of the retirement age for general practice has dropped to 57. So we're losing people who would have previously stayed on the workforce for several more years. One element of that was the taxation issue, which has been resolved last year. But actually, the experience of working in general practice at the moment is not great, and actually we're driving people away. Because there's too much bureaucracy, there's too much admin. Some of the elements of the national response are going to address that. So we're very focused on that locally. We have a wide range of programs. We've appointed several GP workforce leads. We have a local retention scheme, and we are doing our best to both recruit and retain. Nationally, we're waiting for the sort of national NHS workforce plan. I think there is a recognition that we probably need to train more doctors to deal with some of these changes. At the moment, we're recruiting a lot of international medical graduates, which are good. They tend to be, we're a training practice. We have 2 international medical graduates working with us at the moment, but they come from outside the UK. They work in Staffordshire. They often get on a train and go to Manchester, Birmingham, London. There's a drift to conurbation. So we need to build through our workforce implementation group a strategy around making Staffordshire a more attractive place to work and to stay in work, and that's our focus. Back to the community pharmacy, as I say, we have a medicines optimization group, which is separate from our general practice primary care team, but we work very closely with them. They regularly meet with the LPC, the local pharmaceutical committee, and particularly around that community pharmacy consultation scheme. So we're in quite regular discussions around how to maximise that. And as I say, we've got one of the highest usage rates in the country on the CPCS scheme. But I'm happy to feed back through that the comments around the perception that privacy isn't always as good as it should be. As I say, the estates issue, I think, is recognised, and as I say, there will be an increasing shift in community pharmacy to providing some of these wider consultation type services and away from purely dispensing. If you speak to a lot of community pharmacies, the future model is more around provision of services associated with pharmacy rather than the traditional dispensing model of community pharmacies. But with all of those changes, there needs to be changes in the way we provide it and the changes in the estate.
Thank you. Let me bring in Keith Flunder, please.
Thank you, Chair. I just want to make one comment about the fact that you're now looking at weekend and evening openings far more, and I think that's a comment we made several years back on this committee, so thank you for actually listening to us and what people want out there. I'm slightly concerned about the 35% increase in March this year, by the looks of it, in terms of the number of appointments that are required in just 1 month. It seems a hell of a leap in comparison to the previous March. Obviously, you probably don't know and won't be able to know for some time as to the reasons for that. So I'm concerned, as I say, we've already said about GPs, following on really from John's element as well around training and everything else. But rather than looking at it from GPs and your support staff system that's becoming to come in, I'm a diabetic and I always feel as I have to go to the doctor with some of my issues, when really I should be going to someone who's probably got more specialisation than that. How are we going to train up people, and in other words the users, all of us, to get used to this idea that having a privileged, God-given right to see a doctor is something that's probably going to gradually go into the past? How are we going to try and get people to understand that there's other people that have probably got more experience in specialisations and that access to them is probably going to be better than having to go through the GP all the time, which is potentially one of the things that I think is going to be one of your challenges into the future. So I'm just looking at it from an overall perspective. I realise that many people want to see the doctor still, and I'm not saying they shouldn't do that, but I do think there's an element of sort of reprogramming all of us to try and have a look at this different approach, because otherwise I can see hardly any of us getting access to GPs when we want to without there being some sort of revolutionary element to this. So it's a slightly wider question than just in Staffordshire, but thanks.
I've still got 4 other speakers on this, so if we can keep our answers brief, I'd be grateful.
Yeah, the 35% figure, I actually dropped that in my slide deck because I think it was a little bit of, I put the 11% figure in, which is the actual volume that was provided, or increase in volume from pre-COVID. We see quite a lot of variability in the figures from month to month, depending on when bank holidays and various other things have landed. And we actually get the same through our integrated care board meetings when people point out the differing figures month to month. When we actually look at the sort of daily activity, we often find that actually the variation isn't that large. So I'd probably sort of drop back to the 11% increase overall. That's probably the sort of safer figure to look at. On the sort of we need to retrain ourselves. I think it's a really fundamental point, and as I said earlier, I think it's one of the sort of takeaways that from this meeting is that this idea of I'm phoning up to book an appointment needs to change to I have a problem that needs to be resolved. How do I best get it resolved? I think that's going to go through the whole of the NHS, and it's a cultural change for the entire health and social care system and for patients. I think it's a real challenge, and I think that sort of large-scale change will be quite difficult. I do a lot with technology, and I think part of this is we've seen a massive leap in the amount of use of the NHS app. I think we're going to see a lot more connection of patients, and particularly people with long-term conditions, and a lot more digital presentation. I think patients are going to be able to see much more of their own records, their own test results, and there'll be, I think, much more active participation in their own care. I think patients who have actually used some of these other services and other the wider workforce actually have a very good experience of it, and so I think there's I think when patients have been to see an advanced practitioner or they've seen a clinical nurse specialist in a long-term condition, I think they come away fairly pleased from it. So I think we will see a gradual shift in people's willingness to change, but I think digital is going to have a huge impact on this as well.
Keith?
Yeah, just very quickly, just say even an 11% increase year on year would mean that the whole situation could quite quickly get out of control within half a decade or so. So I do think we need to pursue that. I'm not telling you what to do with your jobs or anything, but I think there's something that is far bigger than what we've been discussing today and the immediate implementation of what you're trying to achieve. I'll leave it there, but there's a load more stuff I would want to talk about, my own experience and other stuff. But if you ever get 5 minutes, you can always give me a call. Thanks, cheers.
Thank you. Janice.
Thank you very much. That was opportune, actually, because that was very much what the nature of my question was, and I was intrigued earlier on to hear somebody saying on there about the process of signposting patients. We've got some of the information as to what the nature of the appointment is, who is the best healthcare professional for them to be able then to be directed to. Get that completely. Just taking the point that was made then about the technology side of things, I'm pleased to see that there's still the calling process, because I wouldn't want to see anybody not being able to access it. I know people who can go and book online appointments. How do we use the technology to actually signpost to the best healthcare professional? It can already be a challenge if somebody's phoning in and saying, well, I'm not sharing my circumstances with a receptionist, but that's the person who signposts you. So that's the one that is able to assist. But if that's a challenge at the moment when we're making a phone call, how do you see that working if I'm using the app, which I still can't make a doctor's appointment on? There's an awful lot of functionality in there, and I look forward to being able to do just that. But making sure that we've still got that balance of equal access, whether we are technologically literate or not, and also how we can use that to make sure we are seeing the best healthcare professional, especially using the R's professionals as well. Thank you.
Paddy?
Yeah, that's the nub of our one of our current challenges. So my practice introduced a system called Patches a few weeks ago. I was on call. I was a doctor on call last Monday. And we had, well, I think it was about 120 online requests that came through. It's great. It allows us to spread that work, not just in that first hour from 8 a.m. We spread it throughout the day. We answered them all in the day. Some of them we could answer it's a series of questions that teases out what the issue is for the patient, what they're looking for, what they think the problem is, and allows us to do that signposting online. We could send a link so they could digitally book their own appointment. We could answer it directly. We could phone them up and speak to them. We could bring them in for a consultation. So we had multitude of ways. So I think increasingly the signposting for a lot of patients will be digital. But as you rightly point out, there is a proportion of the population who don't have digital access, and so the current system will stay in place for those patients. When our patients phone up, our receptionists now just go through exactly the same process as the online tool does. The patient experience is identical, but they're talking to a person rather than filling it in themselves. So I think we can standardize our approach to signposting, but we can deliver it in different ways. Behind our particular model is a little bit of AI, which is starting to intelligently filter what's coming through. We give feedback on every call, and we're starting to understand our demand and capacity a little bit better, and we're training ourselves to make best use of the whole range of our team and the people around and about us. And that's what's really behind this modern access to general practice. It's trying to get that sort of really quite broad model to try and smooth. We need to smooth out that 8 a.m. experience, because that's where the majority, 85% of patients are getting what they want. They're just having a bad experience of doing it. So the digital tool will take a sufficient bulk of that away from the phone lines, so the phone lines will unblock and allow us to deal with more. I think this idea that there's limitless demand is probably not true. I mean, I think, whilst you can lower thresholds, I think if we're very clear about what the thresholds for each of our services are, what we do and what we don't do, I think we can become quite clear with patients what each element offers, and then the digital tools and the modern general practice access should make the experience of booking that a whole lot better.
Janice?
Yeah, just very quickly, Chair. And in terms of that uniformity, how and what sort of timescales? Because I know we've had previous conversations when you've got so many different practices. Some offer services, some don't offer services. How is it possible, and certainly the timeframes, to try and encourage them to have that same
I'm
uniformity?
smiling because I thought you might give me the answer to that, but it is one of our challenges. We have 142 practices, and it feels at times that they have 142 ways of delivering this, but in reality they don't. I think we're increasingly trying to get some standardization where we have the modern general practice access piece that's in the delivery plan for recovery of general practice access this year is really clear about the cloud telephony. It's really clear around some of these online tools and the use of them, and there's quite a lot of work that we're doing with all the practices. Will be offered differing levels of support this year. That the plan actually has shifted about £200 to £300 million of current funding into primary care, and given it a real focus around this access piece. So there is a real sense that this is everybody's biggest job this year at practice level and for ourselves. So I'm reasonably optimistic. I think it's a reasonably good plan, and I think we're getting a lot of interest from practices already. We have a work program, and we're going to work through with each of our practices where they are on all of these elements as the year goes forward.
Thanks, Paddy. I noticed there was no date in there, and actually I think Janice makes a really good point, because, and she makes a really good point about not being able to use the NHS app to be able to make appointments. Stuff that we've talked about time and time again. We've talked about internet telephony, and still to be at only 80% when there is a better customer-patient experience feels to me to be really far too slow. And picking up the other differential, which was the 42% versus 100% face-to-face, to me the issue now is not necessarily about access, it's about the variability. And how are you going to drive that so that there is a standard promise to patients? Because frankly, we've talked about this for the last 2, 3, 4, 5, 6, 7 years, and we don't seem to be making the progress fast enough. So could we get an answer to Janice's question as to when? And can the message go back to primary care really clearly that there needs to be one standard promise to residents, which is a minimum standard, because you can't have that level of variability in the system?
I absolutely accept what you've said about the level of variability, and it's something that we use quite a lot in our feedback to practices. And I think the CCG's introduced a program called the Universal Offer, which is a statement around patients across all of the practices should expect the same level of service provided through primary care. We're talking with them about universal experience, and we're building that into the access program. And we also talk tentatively about universal outcomes, which is where we would obviously like to get to in terms of the outcomes from our activity. I think sometimes we often give a range. So you've quoted that 42 up to 102%. It probably would be good for us to present a little bit more data about that at a future ask, because the median is probably somewhat different from either end of that. So if we look at GP face-to-face appointments, 70% of practices are offering more face-to-face activity than national average. So I think sometimes the variability isn't quite the same as what's actually happening in the majority of practices, but that sort of leveling up is absolutely on our agenda. So very helpful for that to be a focus from the ask, and we will feed that back through the team. But we are trying to level up and remove that variability at the bottom end.
Thank you, Paddy. Yeah, I wasn't suggesting everyone needs to see somebody face-to-face, so I certainly agree with that. Useful line of questioning. Thanks, Janice. Charlotte.
Thank you, Chair. Following on from the previous three speakers, I'm certainly interested in empowering patients. And for some patients, that will be a good thing. But what worries me is that by the increasing use of technology and by putting a whole number of steps, self-directed care, or go to the community pharmacy, many of which are now closing, by the way, that we're putting up barriers to people who have complex or multiple health issues. And they're very likely to be the people deterred from going to see the GP. And generally, it is the GP who has the professional training to be able to identify a range of conditions. Now, what worries me is that if you're putting in all these different steps, then those people who don't want to worry their GP are going to be the very people ending up in A&E if they've had to maybe wait for an ambulance for 12 hours, and will find themselves in emergency departments rather than primary care doing what it's supposed to do, which is to ensure that people are treated where they can get better outcomes. And Paddy's already mentioned that the likelihood of getting extra GPs in the short term is very limited. But also I'm concerned that the integrated care hubs that could have helped people who have multiple needs now also seem to be a bit on the back burner. So, it seems to me that we're downgrading primary care when what we should be doing is enhancing primary care. So we take the pressures off secondary and acute care. But we seem to be doing the opposite. We seem to be putting up a whole lot of barriers, which, for some people who are going to mess around with the NHS app and everything else, and when the app is working, great. But, the reality is a large percentage of the GP patient call will be older people who are very easily deflected just by the telephone system, let alone by anything else. And so what are you doing to build in arrangements so that people who really do need a GP appointment face-to-face to deal with some of their complex issues are not deterred from seeking that help? Because at the moment, what seems to be happening is we're all about empowering patients, and we're forgetting about the people who actually need that help because they're either elderly or they have complex needs, which is very difficult for an individual to diagnose.
Thank you. We're with you, Paddy.
Chris might want to come back about the sort of ICS or ICB position around sort of strategy between integrated care hubs and the sort of shift of resources that's been alluded to in terms of primary care. In terms of sort of access models, I think absolutely aware that digital literacy and ability to use some of these tools is not universal, and so we're really clear that the current methods of accessing services will not disappear, but by offering a digital solution, we will move a lot of our traffic into a way that is easier for us to handle, and will then make the experience of people using traditional routes somewhat easier. So I think the digital is complementary and not instead of the traditional routes, and really aware that there are groups of patients who do struggle with that. Interesting, my own experience was that digital literacy was an access to it was often better in patients who were housebound with multiple needs. I had an experience some years ago with the Stafford Blind Centre providing digital tools for people who were deaf and blind, who absolutely transformed their ability to interact and communicate with others. So I think sometimes our thinking around who will benefit from the new technology is we need to rethink, and I think it will probably allow much better care and access for people who are currently struggle with getting to GP surgeries, and certainly the sort of video consultation, the online consultation for a lot of patients really works. But they complement each other. They're not instead of. I think the other thing that's driving this is, one of the useful things that's come out of COVID is an absolute focus on inequalities and the uptake of services across different communities, and built into the whole ICS is population health management, and particularly my interest around our integrated care record, which is now pooling data from health and social care into a hugely useful resource that will effectively allow us to be really clear about all sorts of segments of our population's access and use of services. So I think it's going to be much easier for us to see when there are particular elements of our population who are not receiving the care and the outcomes they should expect. And I think, our certainly, and I was the clinical lead for the vaccination program, our response to that was to tailor approaches specific to different segments of the population. And I think we'll see much more of that. So, I think we'll move away from one size fits all into a sort of multi-channel approach. And whilst, I talk about digital because it will move so much away from our phone lines, it will equally allow us to present tailored solutions to different segments of the population.
I like the idea of a multi-channel approach, but how is that actually going to work out in reality? Because the people that approach me about their frustrations about dealing with the health service, not just GPs, is that actually they all feel as if they're treated exactly the same. You know, and a fit, 20-year-old, as opposed to someone who's in their 80s, you can't expect to treat them the same, but it appears that in terms of access, they are treated the same. So what is the ICS going to be doing to ensure that GPs do give preferential access to people who are not perhaps digitally active or who have multiple issues which really do require a face-to-face consultation?
Paddy?
As I've said, I think the data, because we're looking at the data, and we've got a wide range of clinical programs in the ICS, and for instance, the sort of long-term conditions program, they will be looking at the outcomes across different segments of the population, and we will need to tailor the approach to providing that care according to the different segments and their ability to use the different services. So I think I'm quite optimistic that the future model will allow us to move a lot of our current telephone traffic, which is clogging up and giving people a poor experience, away, and it will allow the people who do have more challenges to actually book their appointments in a more straightforward manner. Whilst I've described the wider workforce, it's only 16% of the current workforce. Our current workforce is still predominantly GPs and practice nurses are the two biggest elements of our workforce, and will continue to do so. The additionality that we're providing through the wider workforce is particularly streamed against things like urgent care. So, I mean, the principle behind the fuller stock take was that general practice isn't one stream of work. It's got a number of different channels. So 47% of our work on a given day is booked on the same day, so that may equate to urgent care. People who want urgent care are often quite happy to come and see an advanced practitioner. What they want is easy access. If you pick your child up and they've got a fever at 4 o'clock in the afternoon, you're less concerned about who you see. You just want to see a competent practitioner fairly quickly. In another element of fuller, which is around personalised care, which from our perspective maps to things like long-term conditions. The approach will be different. You'll be routed to see long-term condition nurses or advanced practitioners who specialise in that particular field, and we've been running that model for a number of years. So if you go for your diabetic review in general practice, you will generally see a nurse who specialises in diabetes or respiratory problems or cardiovascular disease. So there's a range of professionals who specialise in those areas. And then the sort of care of people who have complex needs, so the patients who are elderly, frail, who have multiple morbidities, people who have complex mental health problems, people who are palliative care. That's the particular group who benefit from seeing GPs. And so we will ensure that those patients get access to GPs, because we've got broadly 3 streams of work in general practice, and we have slightly different approaches and workforce models to each of those streams. So that's fundamental to fuller. And again, we need to be more explicit with patients what those different models look like, so that people know what they're getting is the best for their particular problem.
When and what is the time span?
Sorry, we've got 2 other speakers on this. I do want to try and guillotine this debate, so maybe just a one-word answer to Charlotte's question, which is when, just a one-word answer.
Fuller is the fuller stock take is written into our general practice strategy, which you saw the last time we came to OSCE in the spring. That strategy went through our ICS, our ICB meeting in April. It is our current year strategy to deliver that, and so our primary care team is organised around the delivery of that strategy this year.
Thank you. That was clear this year. Thank you, Thomas J.
Thank you. I find some of the talk actually quite scary. So we're talking about downgrading services, lowering people's expectations. frankly, if this doesn't work and you're going to your boss and saying, we're just going to lower your expectations, we're going to deliver less, it wouldn't be accepted. We, the public, are the NHS's boss in this scenario, and we don't accept it. We shouldn't accept it. So we shouldn't talk about just lowering people's expectations. Yes, they should expect to see a GP when they need to see one, and the GP should be there. To sit there and say the plan doesn't include, not even one element of the plan includes looking to recruit more GPs, I find absurd. And again, that wouldn't pass in any business scenario to not have that in there. That should be part of any plan. And we don't talk about process enough. Lots of the issues, I believe, are process-driven, bad processes. I'll give you an example. Recently, I tried to go to the GP, couldn't get an appointment for my daughter, so I had to call 111, who sent us to a local hospital where they had a paediatrician service, right? Let's say, for argument's sake, there's 100 children in there, 80 had the same, I'm not a doctor, 80 had the same cough, the same symptoms. Instead of having a faster service for those who got the same symptoms, we all had to sit there to see the same doctor who asked all the same questions, really slow. I'm not a genius, I'm not a doctor. I could have got that queue down within 4 hours instead of sitting each person 5-6 hours, just through the process. So you don't talk about that enough. And it's not just yourselves, obviously it's much bigger. We've got, you talked about international recruitment. There are hundreds, if not thousands of doctors who want to come here right now. It takes 2 years to book a PLAB test, which is the test they need to do to be registered here. 2 years to do the test, just to be able to book it in. You try and keep anyone interested in the recruitment process for 2 years, it's almost impossible. So, one, I think you should talk about process more, and two, I don't expect really an answer, but take away from this, we should not be lowering expectations, and recruiting more should be part of any plan. If it's not, you've totally got it wrong. Thank you.
Paddy, we're with you.
I apologise if I use the term lowering expectations. I think I probably would come back to the slide I showed, showing that a reasonably significant proportion of people who attempt to book with a GP might have their problem better solved by seeing somebody else in the system. So it's not so much about lowering expectations, it's about sort of a common understanding of who is what the range of staff are and who can best resolve your problem in the fastest and most appropriate way. So it's part of that whole communications piece. In terms of recruiting more GPs, again, we've got our workforce implementation group. We are, it's a huge national and local piece of work. Is about recruitment and retention. In fact, retention is probably more of an issue. We're bleeding out the workforce faster than we're recruiting them. So that is probably our main focus, but recruitment absolutely is part of that. And trying to make the experience of working in healthcare in Staffordshire better is part of this whole programme. But recruitment is absolutely part of our process. But it probably in the next decade is not going to give us an answer to the current problem we have, which is the lack of capacity. So I think that was my emphasis really. We're not going to recruit our way out of it. The likelihood and none of the workforce projections suggest that nationally we're going to GP recruit our way out of this. The PLAB test, we have a lot of international medical graduates through our training scheme and my practice. They're really good doctors, and I'm absolutely aware of the difficulties they face, both in getting here in the first place, but also they struggle with some of the complexities of our examination system, not just the PLAB, and it's a well-recognised issue. And I think there is sort of increasing work to recognise that and make it easier for people who want to come and work here to do that.
And I think Thomas also talked about process improvement.
Sorry, yes. I mean, I think one of the things we're doing, I mean, the ICS has 7 programs of work, and one of them is primary care. But how we interact with other pieces, so the urgent care pathway and primary care, it is about process. I mean, one of the things we talk about all the time is the fact that patients bounce around and move between different elements of that pathway, and certainly reducing complexity, making it clear to patients where how they get the right professional at the right time in the right setting is key to that, because it's one of our productivity gains. So how primary care interact with the urgent and emergency care portfolio, how primary care interact with the end-of-life, long-term conditions and frailty portfolio, these are key things. And it's all around processes and trying to improve productivity and improve patient experience and improve outcomes by trying to make things simpler and more effective.
Thomas?
Yeah, just briefly. So you mentioned you can't recruit your way out of it. Of course you can't. What I'm saying is that it has to be part of a plan. You can't do all the rest of it and not recruit in. So you talk about retention, for example. Yes, it's important. You can't retain people if they'd be more stretched than ever because you've got no one new coming in to pick it up. And if you're talking about changing process, again, what's the first thing that happens when you start to change process? You need resource. If they're already stretched, you're not going to be able to deliver it properly. It's going to be half-baked. I'm in the same position again. And I'm saying this from a position of some authority on changing process within hospitals. I've done work on it. The first thing you do when you're trying to get doctors to change the process is you need their time, which is time they're not got with patients. So you need more doctors. So you can't just focus on the end bit. Recruiting more has got to be part of it. You can't do that on its own. You can't do the other bit on its own either. You need to do all of it. And the fact that even now, you're still not talking about it, it's just wrong. I don't need an answer. I've said it. Take it away. It's just wrong. You need to recruit as well.
Just on that point, I mean, clearly we've got to focus on workforce. I would suggest that we look at this as a strand within the workforce when it comes back in October, November time, which was when it was planned to do so. Philip.
Thanks, Chairman. Yeah, it sounds very familiar, this does. And I've been just sitting and listening to various people talking. My personal experience is my GP is really efficient, but you've got to know what the system is. And I haven't been going to the GP for donkey's years until recently with my back. And once you get into the system, you know. So I think communication, this variance across the county, is quite interesting, because once you know the individual system, first thing that my GP's telephone says, if this is emergency, dial 999 and try the 111 number as well before you rank on. And you'll only take calls between 8:30 and 10 o'clock in the morning, but he will ring you back and listen to what you've got to say. So there's quite a few communication that leads on to my job as a farmer, we have lots of decision trees, which really do help. And with the changes that are going on with the systems that we've got at the moment and doing things for the public good, means that you really do have to think about what you want to do. So you don't just go and use sprays and chemicals, you use alternative methods to stop the problem that you think you're going to have. So there's a little bit about planning ahead, which leads me into the comment about, more GPs. I think it's a bit more complex than that, and recruiting more doctors, because from what you read in the papers, doctors seem to want to go abroad, while we've got people from abroad where they're needed coming here. So there's a little bit more to it than that. And when you're doing workforce restructuring and change management, which I have to say, Chairman, I did for 11 years when I was the leader here, you really have got to dig well into the reasons behind what's going on. And I came out of one about 10 or 12 years ago about GPs and traced it all back to Ken Baker making GCSEs and coursework the way forward in about 1990. Because if you if you sort of put that forward, it made it a lot easier for girls to become medical and GPs. There are not many of them consultants. They ended up as general practitioners. General practitioners are self-employed and want to get out and sell their business to the next generation. And this particular tranche of GPs aren't willing to do that. So there's some real built-in issues that you cannot solve. You won't be able to solve short, medium, but long term you might. In the meantime, in the short and medium term solutions, I would imagine that the best thing to do is try and get these decision trees and let people understand this entitlement. I want to be able to sit in a surgery and see a doctor in 10 minutes. It doesn't work like that. I'm sorry, there's something about that we really do have to get a grip on as a country and be glad of what we've got and also understand that we do have to communicate, or the NHS, whatever that is, primary care, has to communicate with people and say, this is what it is. What can councils do about this? Because our main remit as public health here is to make sure that people try and lead a healthy lifestyle and encourage people to do that, but also there's things that the county doesn't do, but the districts do. And I've got a live planning application to convert an old, very popular girls' school that was a public school into residential properties. In a village of about population 1,800, 2,000 voting age, 2,500 altogether, they're going to convert this school into somewhere around 180 to 200 dwellings, of which 30-odd%, maybe 40%, are targeted at the over 55s. So that will have a direct effect on all the services that we provide as councils, National Health, or whatever it is. I don't know whether anybody's factored into the planning application what the capacity of the local surgery is. I know that the people in Abbots Bromley in that area who were going to the Uttoxeter surgeries, when the houses were built in Uttoxeter, were told that we no longer can serve you, you must go to your surgery in your village. So there's this displacement that happens which isn't built in to the planning process. So it's one way that we can help the NHS chairman. Anyway, I'm not here to have a go at Paddy and Chris and all the rest of it. What I want to see is how can we help solve these problems that are coming along. And I would have said communication, decision trees, and have a look at our own house before we start throwing stones at somebody else's glass house. Thank you, Chairman.
Thank you. We're with you, Paddy, unless, Chris, you want to start, because in some ways this was about a system-wide approach, which I think is what Philip was talking about.
I think we'll get into some of the conversation about responding to changing demographic, changing populations as part of the estate conversation that our colleague Andy is going to lead us out on. So perhaps in the interest of time, Chair, I won't say anything now because I think it'll naturally come up in the next item.
Yeah, then we're fine with that. So very briefly, Daniel, given I'd already decided to guillotine the debate, so very briefly.
Thank you, Chair. Just is it possible to get the slides of the proportions where it was inappropriate appointments, because they don't seem to be in our slides pack, and I think that's a picture paints 1,000 words. And just to say that I think it's been a long time coming for the multidisciplinary team to get into surgeries, because to me that's taking a lot of pressure off secondary care. For example, physios. If you can see a physio at a GP surgery, then it saves you a 2-month wait on getting an appointment at secondary care.
Daniel, with your permission, we'll take that as a question in the estates piece, because I think that's a really critical part to the estates piece. So on that basis, I would like to guillotine the debate now on this one and move into estates. But I did just want to say, Paddy, thank you, and for your support, Chris, for that discussion. You know, I think there is some good news there. There's some good plans, but equally, is it fast enough? You know, what about the variances? Are we taking the general public with us? My other comment in terms of the pack is, you know, there was probably a shortage. Previously, when we've discussed this, there was an action plan, you know, and there were detailed actions and detailed timelines to them. And that was helpful in some ways, maybe too much detail. I think we've had a much more strategic discussion today, which has been helpful. But maybe there is a lack of timelines within the paperwork, and that would probably be the comment I'd make. And also, you know, what does the future of primary care look like in Staffordshire? Because we've not really covered that in sort of, you know, it's a business as usual rather than where does AI and technology play into some of this. But I'm going to leave that there, and we would like to bring you back again. I'm not getting that many nods, so we will have a look at the work programme and decide when we bring you back again, because I think it is a critical part to the work we do. So thank you, gentlemen. Let's pass on to the primary care estate. Can I ask that you have 7 minutes maximum to present. I know that seems a bit rude given you've had to sit through 2.5 hours, but if we are going to finish by 1 at the latest, then 7 minutes, please. Andy, welcome.
Afternoon, Chair. Afternoon, everyone. It's okay, I'll just present my slide deck. Just do a brief introduction to myself.
We can see that.
Lovely, thank you. So, Andy Hadley, I'm the Head of Primary Care Estates and Digital Transformation for the Stafford and Stoke-on-Trent ICB. And I'm just going to take you through a few slides in terms of where we're at as just up on the screen. So as Paddy mentioned earlier, we've 142 practices, and that's actually across 190 buildings across our estate. And what's interesting about our primary care estate is the vast nature of what that's made up of, effectively. So it's made up of local authority owned property, GP owned, NHS trust, other third parties. So it isn't just it isn't just one particular area that owns our buildings. It's made up of a multi-factor of individuals, which then knocks onto different types of leases or other kind of contractual arrangements that exist in the background. So it's quite a diverse area for us to manage and work with. What we're doing as part of that piece of work in terms of really understanding our estate and how diverse that is working to understand and get one single version of the truth. And many colleagues may be aware of the Shape Atlas tool, which is a nationally commissioned piece of bit of software that's available on the World Wide Web, which does present to us. It takes lots of different data feeds, and we input data into there to keep it up to date. And we have a localized version of that as well, which has more specific detail for our own strategic operational work. Why that's so important is because our estates and some of our ongoing work programs need to be very much data driven. So we need to understand where our issues are, what we're doing about them, how we're going to do it, and the data around our estate and what's made up, the usage, etc. is all key. A big part of that is equally that strategic viewpoint of the fuller stock take, which highlights those opportunities of how we and suggests how we might do that as one public estate, which we've worked with local authority colleagues for some time in terms of a one public estate approach. And as Paddy alluded to earlier, we have a GP strategy, and again, lots of pass-through areas, lots of interdependencies with our estate, our access programme, our workforce, and I'm sure that will come up throughout the rest of the presentation as well, and I can highlight some of those points. We're in a process at the moment nearing the completion that every primary care network is having both a clinical strategy and an estate strategy produced. So that's being, again, commissioned by national NHS money, working with a third party and local representation and obviously primary care network colleagues. And that it goes to that point around a single version of a truth and really understanding what our estate's needs are across the area. And then we've actually been invited to follow on that piece of work to be one of the first areas for a national programme in terms of what that would look like as a whole system. So we're waiting for that to expand. Next slide is just a bit of a highlight to our estates charter that we've worked hard on over the last couple of years to build on that one public estate, working on that system of collaboration, moving into the ICS, where we've shared some key themes, and there's a more detailed charter that sits behind this, but really this was just to bring this to the awareness of the committee if you'd not seen it before, and just on how we are going to continue to work as one estate moving forwards, where we're looking for efficiencies and opportunities, and how we bring together the vision of our own GP strategy, the national GP strategy, and that of fuller stock take in terms of integrated network teams and how integral that primary care is to that. So a bit more of a breakdown in terms of what general practice estate looks like. So as per earlier, 990 sites, 48 branches, so 76 of those sites are GP owned. That has other implications onto workforce and partnership models and lots of other details around general practice, because there's some well-known issues, and colleagues may have had these raised by constituents in terms of such a thing as last partner standing, in terms of some of our buildings where partners hold a lot of liability potentially on their estate, and that was referred to in a think piece I think it was published last year or the year before, around how general practice, evolving models, how that could be supported centrally. So that's one area that's really interesting for us, and again will open up opportunities and challenges to us as we move forward. And again, to touch on a build on that further, is that 30% of our estate is built before 1984, with 22 sites before 1948. So we have as part of our estate schemes, we have three pots that estate's going to be categorised into. So it was the first time I'd heard this phrase last week, actually. Our core estate, our flex estate, and our tail. So core being that we obviously want to continue on with. Flex that will either sit between that core, be able to be brought up into core, or flexed down into tail potentially, depending on the level of investment. And tail, where generally we've seen it's a GP independently owned residential property that's been converted, etc., which perhaps is the older model of general practice from years gone by. And again, that connection back to the Access programme, we are facing an increase in pressure in terms of the additional workforce and being able to house those staff in our estate. So that's very true of one of our key pieces of work, that we work closely with our PCNs, our practices, in terms of trying to find them space, which leads on to our void space piece of work. So whilst we are still struggling to find some areas, because obviously we've got 142 practices and a huge amount of sites, we are still struggling to find some, but equally we've got void space in others, and that's a key priority for us in terms of making the best use of our estate. So again, may not be common knowledge, but for void space that isn't used in our buildings, there's still a rent fee that's paid to that. So it's really important we're making best use of that estate, because that is costing the taxpayer money. And then equally, our only kind of source of recurrent investment currently into the NHS is through our premises improvement grant process. So that's a small part of capital money that's provided to ourselves to work with our practices who submit bids against that, and that comes with it a 66% funding from the NHS, and then the practice fund the remainder of those schemes, and they go through a robust process, often requiring planning permission, etc., to get those processed. And we are very much looking forward to all of this data, all these plans we're pulling together, going up into the national bodies for them then to be supported into the spending review moving forwards, and how we will be able to lobby for further funds for general practice and the system moving forwards. I'm conscious of time, so I was going to quickly highlight a couple of points on this slide. And the last one, really about, again, we have a really good, now strong local primary care team focusing on estates, and we have a planning lead who works very closely with all 9 local planning authorities, and who's put in really robust and strong processes so we can take advantage of 106 opportunities and community infrastructure levy opportunities with colleagues. And then also a bit of a nod in terms of we've delivered 2 new developments across Staffordshire and Stoke-on-Trent over the last few years through COVID. I think we were one of the first schemes to be completed out of the Estates and Technology Transformation Fund, which both of our new builds were kind of supported from that national funding. So really proud of those achievements over the last couple of years. And then just a bit of a nod in terms of our collaborative working with colleagues across the system, and how we are already joined up and having good system conversations about how we deliver moving forwards. And then just to end really in terms of our PCN estate plans, they are absolutely key. So we are seeing, we expect our PCN independent plans to be completed by the end of June, with a wider system report being available later in the summer, probably August, September. and then we will better be able to have a view of what our strategic approach looks like from our primary care, and really feeds into that, the how and what we're going to do, which we have great ideas about currently. We need that data to back that up. And then very, very much a case of this is very much about our continuing improvement, and how we're going to support NHS in terms of building that case for funding, and the future needs of general practice across Staffordshire and Stoke-on-Trent to underpin all of those key programmes around workforce access, and much wider primary care initiatives moving forward.
Thank you, Andy, and thanks for your brevity on that. Daniel Maycock.
Cheers, Chair. For the last 2 years, I've been trying to help a practice gain some more premises of a place that lost a premises, and I was trying to speak to what was previously the CCG, but didn't get anywhere. So I think you said earlier about practices having to go and buy or purchase residential properties to then transform them into surgeries. Now, that's good that the practices can do that, but in Tamworth we're suffering with it's nationally housing shortage. So is that right that GPs should be having to go to buy residential properties, which is increasing that problem, but then they're not getting the forthcoming communications from yourselves or previously the CCG to support them in what's stated in here about the rent and supporting new developments? Because they literally have no space. That they've got people who are applying for jobs and they have nowhere to put them. On top of that, there was a development done of 1,500 properties, so double that as a conservative amount for how many people are going to be there. And when our planning team put out the consultation, there was no interest in putting a development site there, even though it's identified for health. Cheers.
Andy, we're with you.
Thank you, Chair. Yeah, so I think Paddy touched on earlier in that future model of general practice, and that may be, it's quite usual that we would not engage with going into a new development area, and and we very much look for how the data we've got around our particular area drives that. So as a Tamworth resident myself, I can see the houses popping up around, and there's lots of activity in that space, and understand the patient flows around the area. The point around the residential properties, I think, is we do have a lot of GPs that have that. That isn't the model that we necessarily is our model moving forwards, but we do have the areas where that's already in situation, has been a historical setup. And we do have processes in place where practices if they are going off and buying their own properties and own schemes, then we ask them to work closely with us, because we obviously need to pre-approve any of those kind of changes. And there's lots of detail in terms of the rent reimbursables and the district valuers, and lots of processes we do have to jump through, and kind of work closely with our practices in terms of ensuring that gets all clearly fed up through ourselves and through to NHS England. And again, that's very much about supporting our practices, supporting our population in terms of that access journey, and also making best use of the space that's available. So I think we do have those processes available, and I know we're working with a number of colleagues in Tamworth where we have got tight on space. I think what's key for us is those PCN estate plans, and what those plans will support us in terms of that opportunities and challenges we have in particular areas, and focusing on where we're going to target that support.
Daniel, do you want to come back?
Chair. With the rent question, it wasn't additional rent that there was going to have, because they already had a surgery, but it burnt down and they couldn't then re-enter that one, so they had to purchase a premises. There'd been an area selected that they could have possibly put planning into, but they needed the go-ahead from yourselves or previous CCG to go into discussions but there was no communications over 18 months coming back to them. And I don't know whether it was the changeover that was happening at the time from CCG to ICB. But yeah, there definitely needs to be more communication there. But to not show interest on a development that's got 1,500 properties, I think is quite shocking with the demand that's being seen in Tamworth at the minute.
Yeah, and I'm sorry, Chair, just to jump straight back in there. Yeah, I'm aware of that particular site and those practices that are involved, and we are working closely with them currently. Certainly aware from our planning lead of the engagement they've had within those properties, so I'd have to kind of take that back offline. But I'm and certainly myself had some initial conversations with some GP leads in terms of those schemes. But I think, you know, without going into specifics, I think that there has been opportunities that have been explored there. And we're happy to link offline if that's suitable in terms of following that one up with yourself and colleagues to address that matter. But I think my team has linked with the local planning authorities on that a couple of times.
Thank you. I'm sure if you send just a written response, Andy, that would be very helpful to Debs, because I'm sure everyone on this committee who's taking houses in their areas would be very interested in the response. So thank you. And that was in part the purpose of bringing you here today. Philip, I'm just going to hold you 2 seconds because I just want to tie it back to a planning discussion, if I may, please. Anne, you asked an earlier question on planning. Was that what you were going to ask here without taking us off the subject?
Yes, Chairman, thank you for that. Yes, thank you. Yeah, I mean, all right, with the rising population throughout Staffordshire, but, you know, looking at Stafford as a whole, I mean, I've sat on the planning meetings for the last 3 or 4 years at Stafford Borough, and health has always been at the height of, you know, what about health? What about doctor's surgeries? What about... And really, there's been no reaction back from anyone regarding that, and that really is concerning. You know, I mean, all right, you look at 2 applications that came in. We're told that unless it's over 500, then you don't get involved. Now, is that correct? I mean, we had 2 applications come in, one with 400 and something, one with another 300. It jutted to nearly 1,000 houses. But because it was 2 separate applications, but only half a mile from one another, nothing happened. And I'm really concerned. I know you say that you do have interactions with the planning department, but please, can you make sure that health is on there on our planning structure in the boroughs, please? Thank you.
And I think there's a supplementary. Can you give us your phone number so you're on speed dial for when we need you?
And it certainly won't be me you want to speed dial. But my local planning lead absolutely is the man to go to. And I did check that statement out, just a query, because I didn't think that was correct from my understanding. And my colleague, Philip Murphy, who's our local planning lead, and who was established, he's been in post just over 12 months or probably 18 months now. And he's worked closely to establish key trigger points with local authorities, and that's in any schemes of 10 units and above. So just to back up that with some further data in terms of the schemes and the work he's done over the last probably just under 18 months, so we've secured in that period 3.2 million in terms of SIL Section 106 funding across our entire estate, with a circa 8.2 million requested. So there's been a substantial amount of funds that are being requested, and so he's very, very much engaged in these processes. So we have a lot of and all that data that I spoke about from those initial stages of the work over the last couple of years is supporting and is fundamental to those requests that are going in, because as colleagues will be aware, the challenges we'll have around planning, where if we don't provide those evidence-based requirements for that funding, then we're unlikely to get refused. So I'm really pleased to see that we've, you know, how much we've secured in the last couple of years has grown and grown.
Thank you for that. Just to say, I will be keeping my eye on the subject, and can I make a plea to other people that's representing boroughs to keep an eye on that when they've got planning applications coming in. Thank you, Chair.
And obviously, in terms of keeping an eye on the local plan reviews, which districts and boroughs are going through, because starting at the strategic local plan level is a logical place to be, particularly in terms of health provision. Philip Atkins.
Thanks, Chairman. Yeah, looking and carrying on from what I was saying before, I'm a little bit surprised that they're only just getting to grips with Section 106 and Community Infrastructure Levy. The County Council, schools run schools. We haven't run them for about 20 years. And that's one of the things that people just do not understand. But we have to provide the school estate. And for that reason, we've always been putting in for education donations from developers and the landowner who sells it to them. 50 houses generates about 17 school places at secondary and primary levels. So we know roughly what's doing that. So I would imagine that 50 houses would generate the need for X places at GP hospital or whatever it may be. Interestingly, though, we were also looking over the last 15 years at extra care, rather than people ending up in nursing homes, get them in a place, because it really does save money on the transport going around umpteen houses to have people in one place where they're enjoying themselves and they've got a life and everything else. So that's why I'm interested in the opportunities that this planning application provides at Abbots Bromley, because it's the first time I've seen somebody privately taking on a massive project like that, which has got conservation, archaeological, whole host of issues that in my developer hat on, I'd run a ruddy mile. I wouldn't want it. It's got a chapel, and so there's a real opportunity there to enable us to help old people ageing and who are not so good glide into old age in a better way, a soft landing rather than a crash landing. And so, so I'm pleased to hear that you've got somebody in there. But one of the other things that we slipped, and I'm going to upset my district council colleagues, was the strategic plan, which some said, well, we don't want that, but you had to have some sort of strategic plan so that we knew that areas like East Staffordshire and Stafford, have taken a lot of housing lately, could have the infrastructures there, because otherwise, as councillors, we just talk about the roads, but I used to, as leader, talk about the schools, the surgeries, the community centres and everything else that people wanted, and the swimming pools. And unfortunately, some people spent it on their pet projects rather than the things that the people really need. So I'm really interested in what they're doing and commend that, what you're doing with the estates. And also identifying what the public will say, oh, there's all those people, they may need ex-GP or whatever at the surgery, but you will know what the capacity is of those surgeries and primary care, because we know, as an educational authority that provides school places, where those school places are needed. And just as very relaxed about it, but we used to find millions of pounds for schools to build them, and then we hand them over to an academy trust for 150 years. So, well, welcome to our world. It's all I'm going to say.
Andy.
Thanks, Philip. Some helpful points in there. I think there's a lot of us. I think a lot of that in terms of, again, that future view in terms of how we can use our state and work with colleagues. Certainly, touches on, and colleagues will be aware of the Northfield site in Stafford, I'm sure, which is a really impressive site, and the work that's happening outwards to in Burton to develop another particular area of great need in terms of our estate. So colleagues that have worked on those schemes are still supporting our estates programme. And I wouldn't want to portray the picture that we've only had a grip on 106 and SIL for the last 18 months. We have had colleagues leading that process, but what we've done in the last 18 months is brought in a much more a more permanent resource and who's been able to better establish those local planning and local strategy links in terms of the town planning processes, so they can really again advance on that and those advanced care needs, and then we're looking at how we again work with a wider system to expand out what those wider requirements are, as you touched on, Philip, around the care homes and what that looks like in the future. Just a bit of a note to this is all changing again, isn't it, over the next 10 years as well, in terms of nationally the infrastructure levy and what that looks like. So we think our strategy and our way forward is very much going to support that approach. And certainly Phil, my local lead, has spoken to some national groups around the work we're doing in Staffordshire and how we've been successful with our numbers, etc. So hopefully that helps to add a bit more context.
Thank you, Philip.
I remember the projects well, Andy. I was there.
And obviously...
and I just hope there's some more in the pipeline.
Yeah.
And we've got... Sorry, can I bring in Chris?
Yeah, I was just going to suggest, Chair, that I know there's a lot of local interest goes into the impact of new housing developments in particular areas onto public services. We do have a very well established mechanism by which we assess the potential impact on public services in any one particular area, and Andy's highlighted Burton and a couple of areas. We've done it recently around the redevelopment of the Rugeley power site. But we are aware that sometimes the detail of that process perhaps isn't visible to district and borough councillors, and sometimes on the face of it, it might seem slightly odd. So I dare say we'll never have the time in this committee to go through those individual issues, but we are always happy to engage with district and borough councillors on specific issues if they've got concerns, and more than happy to explain some of the rationale about how we kind of reach the conclusions that we do.
Thank you. I think there was two things in there from my perspective. One was obviously a point of contact for your team, Andy, whoever that is, presumably Phil, but equally it might be worth circulating around committee what the model is for assessing sites so that people have got visibility. And then if we want further information, we can come back to you on it. I'm sure it'll be very interesting to district and borough colleagues. And obviously Northfield Village is in Stafford and is award-winning. And I think is a really good template as well to show what is possible with creative, imaginative thoughts about public estate. Janice.
Yeah, thank you, Chair. It sort of brings in both of those aspects, actually, and as a district councillor as well, I'm sure that I, for one, would be very willing to be able to get involved and to support those. And I know that certainly Lichfield's Overview and Scrutiny Committee, if I speak in a different capacity, welcomed the attendance recently. That attendance was in light of the fact that we have a significantly sized practice which is likely to close in advance of a new one being built and causing a great deal of local anxiety. So my point really was in terms of the horizon scanning. I understand some of the background to that and the contracts and the difficulty extending contracts before the new one is there. But potentially we have the issue there of 5,000 patients being farmed out across other local practices who apparently do have capacity, but in this particular part is reported widely that it's difficult very much trying to access those, going full circle again. But my concern in amongst all of that was that social media locally led the communications and in some cases still do when it comes round to getting the message across. I appreciate Lichfield no longer has a local paper, but that is one of the mechanisms that at the moment I think isn't necessarily helping that transition by a long stretch.
Andy?
Yeah, I think, again, aware of the particular scheme, I think there is due process, I think, in terms of, again, that we'll go through in terms of how those changes are made. And I think there was a clear process and a line of communication that we were planning to go through, and some of that obviously was stripped out into social media. I'm not aware of the conversations that were had at Lichfield's Scrutiny Committee. But I think what I would want to portray is just that assurance that we will continue to work with practices and ensure our population are updated with the right information at the right time moving forward. I think that's obviously a key requirement and one that we want to continue with. It's probably an important reflection on that point.
Thank you. Janice?
Yeah, I think there is a lot still to be done there. There's an awful lot of house building that has been done locally as well, and I'm sure the residents of Burntwood would very much welcome the new practice. It's just a shame that it's not done in advance of. But yes, the communications, I think, is what is causing the most anxiety locally at the minute.
Okay, given that we're now revolving into local-based issues, I'm going to move that conversation on, if I may. Chris, I notice you indicated, can we not talk about that specific practice? I am cited on the issues.
Yeah, so I was going to respond on that particular issue, Chair, so I shall withdraw my hand, but happy to pick up conversations that's had here with relevant councillors.
Thank you. Let me just very quickly bring in Richard Cox.
Thank you, Chairman. I just wanted to question in the 76 or 40% of the GP estate is GP owned. Now, to me, this is where you've got a problem. And how do you overcome that problem? By perhaps taking, new build, ensuring that it's in your control rather than the GPs, because I think that's where there's a distinct issue here, and maybe it needs to be really investigated and to have a tangible outcome, because that outcome, I think, will be to the benefit of our residents.
Andy?
Really helpful point really there for us, I think, in terms of, building on what I said earlier about that data-driven approach of acknowledging that point, the what we want to get to, how we're going to get there, what support we need in terms of managing that transition, what that's going to provide in terms of opportunity, also to practices and to the population are really important. I think it's a well-known issue, not just within Staffordshire and Stoke-on-Trent. That's a nationally statistic, I think, that's replicated in terms of high GP owned, and again is referenced in one of the later plans that we've had in terms of what the focus in terms of our building of our estate strategies. Equally, what's going to support this process is by the end of this financial year. So I think we're working to a draft report date of our ICS infrastructure strategy, December this year, and then with revisions moving into April or end of March, where I think those points will be absolutely clear for us to develop on in terms of how we are going to address that. And I think that's equally going to be just as much as that challenge up to the centre around the capital, the funding, ongoing procurement, etc., resources support in order to address that particular issue. And again, I think that's just as important for us as from an estates perspective as it is for those services. So again, there's lots of emerging thoughts, I think, and notes that of how supportive that will be to colleagues, and will support our future view of primary care in terms of that shape and size and delivery mechanisms, bringing in the integrated network teams. Colleagues spoke around access and going into one place for a range of care. They're the models we would want to support and drive moving forwards.
Richard, can we?
Yeah, I'm just happy to see. I'd like to see that come forward very much so. So I look forward to that day.
Thank you. Just before I bring in Daniel very quickly, and no, he doesn't want to come in, that's fine. I did have a question I wanted to ask, and it relates a bit to Richard's question and moves to more of the strategic issue, which is, are the estates fit for purpose in a modern day operation, i.e. for ease of access for all patients, Second of all, to cover infection control, given what we learnt about COVID and the pandemic. And thirdly, to be able to house under one roof all the services that primary care can take in, because I'm not as convinced by any of that and I would like to be, please.
Yeah, thank you, Chair. I think it's. I think we can say from a strategy point of view, you know, a lot of those, a lot of things we've discussed today aren't going to be solved overnight. You know, we're working on our system plan of how that's going to be done over the next decade, if not longer, and that's going to need strong collaboration locally, lots of support from our system, and other colleagues, and. To the point around where our estate is currently, I think we are finding that in spaces there's some that you know aren't up to the current standards, but they are safe and they are able to be moved forward. But if we are comparing to what standards are now and what we would put into place, they don't match, and that's part of that wider system. And again, going back to that data is driving us to highlight those positions and how we're going to work with colleagues to address that moving forward. But yeah, it's definitely an area where we see there needing to be significant investment from the centre. Chris, do you want to add to that? Sorry, notice your hand go up.
Yeah, I just wanted to say, as a direct answer to the direct question, Chair, I think we know that in some circumstances that, you know, the current model of our estate would fail against those tests. I think Andy introduced the kind of age of the estate earlier on and said that you know, a proportion of our estate is pre-war. Some of it is pre-1983 or 84. I think, you know, self-evidently building standards and clinical standards have moved on considerably in that time. So we know that you know, if we were building estate today, some of the estate we've got would not fit with those provisions. I think equally in terms of access, you know, car parking provision, location geographically, then I think some of our estate has got some questions to ask. As Andy says, our emphasis is making sure that services can be delivered safely from those sites, and that we've got a really clear strategy on what we're doing in terms of going forward. Outwards in Burntwood, we've got the Darwin Centre in Burntwood, outwards in Burton, the Darwin Centre in Burntwood, Northfields in Stafford are examples of the types of model we want to get to. Although it is also true to say, just referencing briefly back to the conversation around the practice in Burntwood, that the process of getting there is sometimes difficult.
Really useful and a good place to finish this morning's or this afternoon's debate now. So in terms of what I think we've just discussed as part of this item, we talked very much about planning gain and how you're maximising that opportunity, because it obviously gives you a greater demand on services. Equally, that you're applying creative thinking to the estate across the board, but you do recognise the need to improve the estate as it stands, and actually by coming up with a 10-year plan, at least there's something to work to, and will get us there in the medium term, if not in the short term. So if I can thank you, Chris, your team, Andy and Paddy, for your time this morning, just talking through the various bits, been really useful, and I'm sure will be as part of a continued ongoing dialogue. So you're welcome to stay with us, you're welcome to leave, and thank you for your input.
Okay, thank you. Thank you all.
Thank you.
Bye.
So that brings us on to item number 7, which is the District and Boroughs activity. We've already, we haven't already done anything. We've had very few meetings of the new calendar year. The only update I think I've got is for Tamworth. Is that right?
Yeah, thank you, Chair. Basically just a meeting on the developing healthier communities workshop that was done last summer. The write-up in the pack is a little bit short, but I've sent you a more substantive email which can be sent out to the committee. Chair.
Thank you in the use of time. Thank you for doing that. I would just say that Tamworth have done a lot of work in terms of the offers from this committee to work collaboratively on public health and maybe a good direction of travel for new district and borough colleagues. And if you want to talk that through with the public health lead, we can facilitate that discussion. We can join in that discussion with you. But I can also reference very much the work that's been done within Tamworth. So thank you for that. Shall we note that and move on to the next item on the agenda, which is the work programme. You will see in front of you the work programme with the various meeting dates that are in the diary. We've obviously added in this morning to Re-See Dental in October, where we will see the recovery plan that they're talking about and some more of the detail. I think we understand what the issues are, but we'll at least get some more detail to go around that. And in terms of the workforce plan, that was already scheduled to come back on the 16th of October, both in terms of the social care workforce, but also adult social care workforce, but also the ICS and the separate strand under primary care that we talked about. John.
Yeah, thank you, Chair. Yeah, forgive me if I've missed it, but my laptop's died now. But I couldn't see anything on there regarding ambulance provision, and given the continuing abysmal performance, particularly in the rural areas of the ambulance service, not all their fault, I grant you, but a fair proportion of it is their fault. I'd like to see that continue on the work programme, please.
So just on that, two things. First of all, we did do a quality accounts review on West Midlands Ambulance Service. It would be worth us sending that around committee if we haven't done so already, just as a historic looking back, because I think the major outcome from that was actually giving us the whole of the West Midlands data is particularly unhelpful for Staffordshire, particularly when you look at the rurality of what we're talking about. So I think that's got some relevance. But we've got the West Midlands Ambulance Service coming to us on the 24th of July, and subject to that session, can I suggest we just refresh that conversation in terms of whether it hits the bit that you're specifically interested in?
Okay. Yeah, thank you, Chair. Thank you.
Thank you. Janice.
Chair, is it convenient just to make a comment on the women's health strategy?
And you may need some additional colleagues on your work.
Well, shall I take it from the beginning for the new members especially? So following the publication of England's Women's Health Strategy, this committee put together a small task group. And we made a strong start, and certainly members of the task group at the time put together a fairly comprehensive list looking at what could present further opportunities for investigations for the female residents of Staffordshire. We then were thwarted slightly by waiting to get a contact, but in April, and I'm afraid Tracy's just left, because I wanted to thank Tracy, because she did in the end pass over the name of Dr. Rachel Galliot, who is the women's representative for the ICB. So we now have a contact there. Clearly, we have opportunity now to refresh the composition of that task group, and I'd certainly like to extend an invitation of anybody who would like to take part, but I dare say there will be some direct communications with yourselves anyway. Hopefully, thank you very much, Deb, to be able to put together that group again where we can start taking it forwards. Thank you, Chair.
And just in terms of that recruitment of additional volunteers, are your meetings face-to-face, online? How do you do it?
Absolutely. So far they were online, and I think that worked well for the majority of people because geographically we were really quite spread out, and I think that served well. So online is definitely the way forwards for me at the moment. Thank you.
So I think there's a request for volunteers. You could do that now. or approach Janice later in terms of reference if you just want to check the terms of reference, but please can I encourage members to do that. Richard, were you going to talk about the integrated care hubs, or is that me?
I think it was you, but I don't mind.
Okay, so there is also a similar working group which covers the integrated care hubs for the north of the county. That is made up of 4 councillors from the Moorlands and 4 from Newcastle-under-Lyme. We've lost a couple of the previous working group members, so we would like to try and recruit to that 4, so there's an even balance. The working party is chaired by Richard Cox, and there is work going on to deliver some of the integrated care hubs, and you'll be aware that we are very much committed to and a fan of the integrated care hub model, and that is part of NHS England's strategic plans going forwards. So if we have anyone from the Moorlands or from Newcastle who wants to volunteer for that. Sorry? Okay, we've got a tentative, but let's use pencil, and then we can ink over it later.
Seriously, Chair, if I may, when does that meet? Does it meet in the evening, during the day? When does it meet?
We've met in the evening. We've had some meetings that have been through Teams, but previously we actually had site meetings just to see what the sites were in question. There's 2, 3, but our meetings have been on Teams.
I'm already involved, so count me in.
And there is some movement because, you know, as soon as that group is constituted, then I'm sure we can just update individual members on the movements that are moving forward there. But they're working on the business cases as we speak. I do think it is worthwhile getting the right representation there, because it will provide facilities for the next 10 years or more for local residents in the north of the county. Just bearing in mind time, in terms of the work programme, does Daniel?
Cheers, Chair. Just wanted to know if the George Borrance Centre was coming back before complete sign-off, because I can't see it on the work programme.
I'm not sure if it's scheduled to come back unless there is a fundamental change, because this committee decided it wasn't a significant change to healthcare provision. So I think we would just need to see what information led it to come back. I mean, we're clearly aware and being briefed, as is the local councils, Tamworth and Lichfield, on that. But unless there was something significantly new or different, I wouldn't be suggesting that it would warrant committee's time. If there is something new and different, then we should look at it, look at it as it comes up.
I think it was just more about the travel arrangements that they were still trying to figure out, because obviously that was the main concern, which they still hadn't penciled out and was going back to NHS England.
Yeah, obviously that was an action that was agreed with between committee and the provider, and we would want to see that action has been discharged. So yes, in that respect, we would probably do it by a written response, probably, to use committee's time in the best possible way. So I'm going to, any other points? I'm going to suggest we've got a very long list. We've got a committee agenda which takes us through till about October time. We could be really sort of ruthless and try and programme these all in now, but I think the problem is that leaves us with less flexibility later in the year. So I would suggest we look over the next month or so. There's a couple of training sessions that we're doing, one on adult social care, which is at the end of July. There's a general committee training session which is in 6th of July, is that right? Thursday, the 6th of July. So I would suggest we do those general training meetings and upskilling, just so that everyone's got the same language and perspective and starting point. And then we do a bit of programming from there if committee is happy. Thank you. And on that basis, it's been a long meeting, and I will wish you a good afternoon. Thank you for your input.